Hello everyone. Very good morning to all of you. I guess I'm clearly visible, audible. Kindly write down in the chat box if I'm clearly visible, audible. Very good morning to all of you. I welcome you all for today's session. So a new morning, an enthusiastic day, a new day. Today we are going to crush entire pharmacology, right? So this is a rapid revision of the pharmacology. We will do in 2 days, half today and half tomorrow. So I will let you know what are the topics for today. Okay, so kindly let me see if I'm clearly visible, audible. You can write down in the chat box. Okay, thank you. Thank you for confirming. Thanks a lot. So let's start it. You can see I am going to take entire rapid revision of the pharmacology in a crux. So I will tell you all the important topics of the pharmacology which are important for your competitive exam, maybe FMGE, maybe NEET PG and NICT. So we will do it rapidly and let's start it. So these are the topics of entire pharmacology which are important in your syllabus, from which maximum question comes in your exam. So today we are going to target with the general pharmacology. We will start with the pharmacokinetics, followed by pharmacodynamics, followed by the most important, the biggest chunk in the pharmacology is the antimicrobial drugs. Here we will take all the antibiotics which inhibit the cell wall synthesis, that is beta lactams. We will take the protein inhibitors, protein synthesis inhibitors. So we will take all the antimicrobial drugs in a crux here. After that we will come on the renal system, where I will take the important topic, that is diuretics. Then the respiratory system, where we have to take the drugs for asthma. These are the topics for today. We will try to cover maximum today, and I guess these are the topics for tomorrow. Tomorrow also we are having the session. So tomorrow most of the topics will be from the systemic pharmacology. So this is the way we are going to start. Okay, so can we start? Can we start? Give me a thumbs up in the chat box. Are you people ready? Can we start? Can we go ahead? So let's start it. Let's start with the first topic, that is pharmacokinetics. Okay, we will focus on all the topics in any particular chapter or any particular unit on which maximum MCQs comes in your exam. Okay, so let's start with the first topic, pharmacokinetics. Before starting pharmacokinetics, you must understand the two branches of the pharmacology, that is pharmacokinetics and pharmacodynamics. So what is pharmacology? I'm teaching you pharmacology, right? Of course. So what is pharmacology, by the way? Pharmacology is the study of the drugs. In the pharmacology, we are having two branches, pharmacokinetics known as PK and pharmacodynamics known as PD. So we are having two branches in the pharmacology, pharmacokinetics and pharmacodynamics. Now let's understand what does it mean. So what is pharmacodynamics? Okay, listen here. You can see this diagram and understand the meaning of both. Okay, listen now. So this is, imagine this is a GIT. You can see the human body, the structures of a human body. This person is taking the drug via oral route. Can you see? This is the oral route. Via oral route, the drug is taken. So drug is going in the mouth. Most convenient and cheapest route is the oral route only. Okay. This person is having some disease, some problem for which the drug is prescribed. The medicine is prescribed. The drug, the medicine, the person is taking via oral route. You can see. So the drug is going in the mouth. Then it is going in the esophagus. Then it is going in the stomach, and then it is going in the intestine. You can see it is going in the intestine. Now, some drugs are absorbed from the stomach and some drugs are absorbed from the intestine. I will let you know which drugs are absorbed from the stomach and which drugs are absorbed from the intestine. We will come on that point. But ultimately, the drug gets absorbed. So the first thing we take the drug is the absorption. The first step is the absorption of the drug. What do you mean by absorption? What do you mean by absorption? Absorption is the movement of the drug from the administration, from the point of administration till blood, till circulation. So from the point of administration till circulation, the movement of the drug is known as absorption. So here, because the drug is taken orally, it is absorbed from the stomach and the intestine. Suppose I am the subject, I am the person. I have taken a drug via oral route in the mouth. So the drug is going inside. First it will go in my mouth, then it will go in my esophagus, then it will go in my stomach and intestine. Now some drugs are absorbed from the stomach and some of them are absorbed from the intestine. So this is absorption. After that, the drug is in the blood, that is in the circulation, right? Now I may be having some disease. That's why I have taken the drug now. For example, I'm having migraine headache. I'm not having, suppose I'm having, for example, I'm having migraine headache, or I'm having heart failure, or I'm having diarrhea, I'm having constipation, I'm having any disease for which I'm taking the drug. So the drug, after going in the blood, it is supposed to go in that particular organ because the receptor for that drug is in that organ. If I'm having migraine headache, the drug I have taken, the receptor for that drug are present in the cranial blood vessels. So from the blood of the person, the drug should move to the site of action. The site of action, this is site of action is different. depending what disease the person is having. The person is taking the drug for diarrhea, so this organ is intestine. The person is taking the drug for some heart problem, the organ will be the heart. The person is taking the drug for the headache, the site of organ can be the brain. Okay, so site of action, the drug from the blood will go to its site of action. Blood goes everywhere, but the receptor for that drug is present in that particular organ. So drug is going to its site of action and shows its mechanism of action there. So drug is treating that disease, curing that disease by showing its mechanism of action in that particular organ. So this is known as, what this is known as? This is step number 2. This is known as distribution. This is known as distribution. What is the meaning of distribution? It is the movement of the drug from the circulation to the site of action. Now you tell me what is the meaning of absorption and what is the meaning of distribution. Step number 1 was absorption. Step number 1 was absorption. Step number 2 is distribution. Absorption means movement of drug from administration to circulation, and distribution is movement of drug from circulation to site of action. Okay, I hope you are getting it. Now, the drug already shown its mechanism of action. It is no more needed in the body. It has already shown its mechanism of action. The disease is cured or controlled, whatever. It is maintained. Okay, whatever drug can do, the drug has already done that. Now what? If I have taken a drug, I cannot keep it in my body forever. I have to excrete it. I want the excretion of the drug. Okay, I want the excretion of the drug. From where most of the drugs are excreted? Most of the drugs are excreted in urine via kidney. So the drug will go in the kidney, and I suppose the drug should be excreted out in the urine. I suppose that. So this step is known as excretion, but it is not that way easy. No, excretion is not directly possible. I want excretion of the drug because it has already shown its mechanism of action. It is no more needed. I want the drug to be excreted out of the body. But there is a problem. There is a catch. What is the problem? In the urine, only those drugs are excreted. Urine is what? Urine is water. It is liquid. So only those drugs will be excreted in urine which are polar in nature. What do you mean by polar drugs? Polar drugs are the drugs which are soluble in the water. But the problem is that most of the drugs are non-polar. So if a non-polar drug is going and asking the kidney to get excreted, kidney is saying, no, I cannot excrete you because you are a non-polar drug. First you go to the liver, ask the liver to convert you from non-polar to polar. Once you get converted into polar, then come to me, then I will excrete you. Kidney is saying this. So this drug will go to the liver. Now, before excretion, we want the drug to get converted from non-polar to polar. So this drug get converted from non-polar to polar form inside the liver. And this step in which the drug is converting from non-polar to polar inside the liver, this is known as metabolism or biotransformation. One and the same thing. Metabolism or biotransformation. So this is the step we require before excretion. So step number 3 is metabolism or biotransformation, in which inside the liver, the drug get converted from non-polar to polar. And after getting converted to polar, it will again come in the blood and then go to the kidney for excretion. So what are the 4 steps? Can you tell me the 4 steps in a sequence? What are the 4 steps, people? First of all, we want the absorption of the drug. Then we want the distribution of the drug. Then we want the metabolism or biotransformation of the drug. And finally, we want the excretion of the drug. So these are the 4 steps. Absolutely right. You can say absorption as A, distribution as D, metabolism as M, and excretion as E. So you can make a mnemonic if you wish. It is ADME if you want. If you don't want the mnemonic, you can understand. So first absorption, then distribution, then metabolism, then excretion. You can understand their meaning. I mean, meaning is more important. Absorption is movement of the drug from the site of administration to circulation. Distribution is the movement of drug again, but from where to where? From the circulation to its mechanism of action, site of action. Then metabolism is conversion of drug from non-polar to polar in the liver. And finally, excretion is eliminating the drug out of the body. So these are the 4 steps. These are the 4 things what the body is doing on the drug. What the body is doing? Body is first absorbing the drug. Body is then distributing the drug. Body is doing metabolism of the drug, and body is excreting of the drug. These are the four steps which are seen in pharmacokinetics. Pharmacokinetics. So what is pharmacokinetics? Pharmacokinetics PK. What is pharmacokinetics? What the body is doing on the drug. Body is absorbing the drug, then distributing the drug, then metabolizing the drug, and then excreting the drug. These are the 4 things what the body is doing on the drug. You can learn the mnemonic ADME. As I told you, metabolism is also known as biotransformation. The meaning is the same. Okay. Now what the drug is doing on the body? What the drug is doing on the body, that is pharmacodynamics. Pharmacodynamics is what the drug is doing on the body, not body on the drug. The drug on the body, what the drug is doing on the body. Drug is doing only one thing on the body. What's that? What's that? Drug is doing its mechanism of action. Can you see? This is the mechanism of action. So drug is showing its mechanism of action in the body. So pharmacodynamics have only one branch, that is mechanism of action. But pharmacokinetics is having 4 steps, you can see. So here drug is showing its mechanism of action. So what we have learned till now? So till now we have learned pharmacology. Pharmacology have 2 branches. What are the 2 branches of pharmacology, people? Say. What are the 2 branches? Pharmacokinetics PK and pharmacodynamics PD. Okay, these are the 2 branches. What is the definition? PK, PD. PK, what the body is doing, body does on drug. What the body is doing on the drug. And PD, what the drug is doing on the body. Drug does on body. Drug does on body. So you can learn D for D. D for drug. D for D. You can learn like that. Here we are having 4 branches. That page is gone. So in pharmacokinetics and pharmacodynamics. Pharmacokinetics we have 4 branches. Absorption, distribution, metabolism also known as biotransformation, and excretion. But in pharmacodynamics we have only one thing, mechanism of action. That's it. This is the summary. Please learn it. If you understood the basic, I can go ahead. I want your thumbs up. Got it? Everyone got it? So these are the 2 branches of the pharmacology. Pharmacokinetics, pharmacodynamics. Pharmacokinetics having 4 steps and pharmacodynamics have only 1 step. This is what the body is doing on the drug and this is what the drug is doing on the body. I hope you all got it. I want a notion that you got it. Give me a note, give me a gesture, give me a thumbs up in the comment box so that I came to know that you got it. If you have any doubt, you can write your doubt specifically in the comment box without hesitation. I will repeat. Anyone having any doubt? Can we go ahead? So these are the 2 branches. I hope everyone got it. We will solve parallel MCQs also, which are already asked in your various competitive exams. So basically we will solve the PYQs based on that particular topic parallel, topic by topic. So some MCQs based on this basic concept. First question is in front of you. Read the question, tell me the answer quickly. Read the question and tell me the answer quickly. Pharmacodynamics deals with what? I'm asking for pharmacodynamics, not for pharmacokinetics. I'm asking for pharmacodynamics. Read the 4 options. The 4 options are, it is effect of drug on body, yes or no? Or effect of body on drug, yes or no? Is it absorption of drug or metabolism of drug? What do you say? What do you say? So yes, D for D. It is the effect of drug on body. D for D. Not body on drug. So correct answer is A and you all are amazing. You all are right. If I change the question, instead of pharmacodynamics, if I ask you pharmacokinetics, what is your answer in the same question? In the same question, would you like to change your answer? Yes, the remaining 3 will be the answer. Pharmacokinetics it is the effect of body on the drug. This is also correct. It includes absorption of drug. This is also correct. It includes metabolism of drug. This is also correct. So the remaining 3 options are for pharmacokinetics. All 3 are correct. Okay, chalo. Coming on the next question. The next question is in front of you. You can read the question. Pharmacokinetics include all of the following except. Don't miss the word except in the question. So they are asking for pharmacokinetics. Pharmacokinetics include all of the following except. What is not included in pharmacokinetics? Can you tell me that? What is not included? Absorption is there or not there? Distribution, adverse effect, excretion. I told you there are 4 steps in pharmacokinetics, ADME. Absorption, distribution, metabolism and excretion. So of course absorption is there. Of course distribution is there. Of course excretion is there. But adverse effect is not a component or step of pharmacokinetics. So the correct answer among these is C and you all are right. So questions are very easy if you understand the concept. I can twist the question multiple times, but the concept remains the same. Okay, read the next question. Pharmacodynamics includes what? Pharmacodynamics. Again, the same question with a different language and options. Pharmacodynamics includes what? Is it drug elimination, drug excretion, drug absorption, or mechanism of action? Pharmacodynamics have only 1 step. What the drug is doing on the body. What the drug is doing on the body, you tell me. Drug is showing its mechanism of action on the body. Yes, of course. So correct answer is D and you all are right. So let's come on the next topic quickly. So is this speed is good? Am I too fast or is it okay? Slow is definitely not there. So is it okay or is it fast? Shall I modulate the speed or you are comfortable? Because it's a rapid revision. I'm assuming you've already read everything once. It is just for brushing up your concepts and just for rapid revision of entire crux of pharmacology. Is it okay? Very good. Thanks a lot. So coming on the next topic quickly. Now let's start with absorption. I will teach you 4 steps one by one. Absorption, distribution, metabolism, excretion. So first we will finish pharmacokinetics, and then in the pharmacodynamics, I will tell you the mechanism of action later on. Let me first concentrate on this. It will require nearly 40 minutes to complete this. 30 to 40 minutes. So let's start with the absorption. So how the drug get absorbed? What are the factors? There are various factors. What is absorption? It is the movement of the drug from the site of administration. This is administration till circulation. The drug is reaching in the circulation. So the movement, no, it is not necessary we are giving the drug every time orally. There are various routes by which we can introduce the drug in the body. We can give the drug intranasally. We can give the drug IV, subcutaneous, intramuscular. It can be via rectal route. It can be via vaginal route. It can be transdermal. There are various routes, you know that. So whatever is the route, from that side, the drug must reach the circulation. If you are giving an intramuscular injection, for example, intramuscular injection, so blood is the drug is going in the muscle. From the muscle, it is absorbed in the blood. So ultimately, from the site of administration, whatever it is going to the circulation. So this movement is known as absorption. So there are various factors on which absorption depends. I will not explain you all because question comes on only one, the pH. So absorption depends on pH. Let me give you the concept of the pH. There are various factors by which the absorption can be affected. Absorption can be affected, the various things present in the stomach, the food, okay, various things are there. The solubility of the drug, the formulation of the drug, the concentration of the drug, various factors. But the most important among them is the pH. What do you mean by pH? Now let me explain you here only. Now please understand. There are 2 types of electrolyte. Drugs are electrolytes, okay? Drugs are electrolytes. Okay, G. There are 2 types of electrolytes, strong electrolytes and weak electrolytes. Okay, you understand this? You have read chemistry in your childhood and you understand this. Weak electrolytes, maximum drugs are weak electrolytes. Some of them are strong also. The strong electrolytes absorption do not depend on pH. They do not depend on pH for their absorption. They depend on lipid solubility, the strong electrolytes. But the weak electrolytes depend on pH. The absorption of weak electrolytes depends on pH. Now, weak electrolytes are again of 2 types. They can be weak acid, they can be weak bases. So we have 2 types of drugs, weak acids, weak bases, and their absorption depends on pH of the organ. So please understand what we are discussing. We are not discussing about the strong electrolyte. No, strong acid. Here also we have strong acid, strong base. But their absorption is independent of pH. Please understand it very clearly. We are talking about the weak electrolytes, the weak acids and weak bases. Their absorption depends on the pH. Okay, so let's talk about the weak electrolytes. Okay, weak drugs, weak electrolytes. So there are 2 types. They can be weak acid and they can be weak base. Okay, weak acid or weak base. What do you mean by weak acid? What is an acid? Say some examples of acids. Say, ma'am, HCl, it contains a proton. Say H2SO4, it contains a proton. HNO3, it contains a proton. So all of them contain a proton. Okay, proton is H. Okay, hydrogen, 1 H positive. That is a proton. So let's say the formula of acid is HA. A is my drug. H is the proton. It can be HCl, HNO3, H2SO4, whatever. H is the proton. So this is the formula for acid. I hope you are getting it. And what is a base? Say some examples of bases. Say, ma'am, NaOH. Okay, it contains a hydroxyl ion. KOH, it contains a hydroxyl ion. CaOH twice. Okay, it contains hydroxyl ion. So I guess everyone know that all bases contain hydroxyl ion. So what the formula of the base is BOH. OH is my hydroxyl ion and B is my drug. So here my drug is A. I hope you are getting it. And here my drug is B. You can see here my drug is B. Here my drug is B. Okay. This is the proton and this is the hydroxyl ion. This is a formula I have created. The weak acid is HA, the weak base is BOH. So basically we are having 2 types of drugs. HA, it is an acidic drug, the weak acidic. And BOH, this is a basic drug. You are getting it or you are not getting it? Okay, you are getting it. So these are the 2 types of drugs we have. So whenever we take a drug, the drug go inside and it get ionized. It get ionized. How does it get ionized? So this is the acid and this is the base. Okay, let me write the acid and base here. This is an acidic drug. It will ionize like H positive and A negative. And this is a basic drug, BOH. It will ionize like B positive and OH negative. Where is my drug? I'm not interested in the ions. I'm interested in my drug. Where is my drug? So drug is present in 2 forms. Here is A. A is my drug. So A is present as like this also and A is present like this. And here my drug is B. B is present like this also and like this also. So the complete form is known as unionized form. This is unionized means unsplitted. It is not splitted. Unionized. And the splitted form, which is having a positive or negative charged, it is known as ionized form. This is ionized form. Okay, here also this one is unionized. B is my drug. My drug is B. Here B is unionized. Unionized. And here you can see B is having a charge. So this one is ionized. So I hope you are getting whether it is an acidic drug or basic drug. It is present in two forms. Please understand the two forms. You people learn the concept. You don't understand it. I'm trying to give you the concept so that you can understand rather than mugging it up. So please understand, in the human body, just suppose I'm taking a drug. The drug is going inside me. So it is having ionized form as well as unionized form in my GIT. It will get ionized. Okay. So ionized. So there is a rule. Please learn the golden rule. Body absorb ionized form only. Body, like the complete form of the drug, absorb. Body absorb ionized form and body excrete the ions. Body do not retain ions. Charges are not good for the body, no? So whenever a drug is having a positive charge or a negative charge, body excrete it. So the ionized form is excreted from the body. Please learn like that. It is excreted. It is excreted. Unionized form is absorbed and ionized form is excreted. Okay, suppose I'm taking a tablet. See, I'm taking a tablet. Now it is going inside my stomach and intestine. In my stomach and intestine, it will get ionized. Now, depending on the proportion, what is the percentage of this and what is the percentage of this, it will decide how much drug will be absorbed and how much is excreted. Depend on the percentage out of the 100%. Out of the 100% tablet I'm taking, how much remains complete and how much get ionized? It can be 80-20. It can be 20-80. If it is 80-20, 80% is absorbed and 20% is excreted. If it is 20-80, 20% is absorbed, 80% is excreted. Who knows? So it depends on pH. pH will decide what is the percentage. You are getting my point. Now I will come on the pH. Please understand. Got it? You are getting it. Here also, the complete is absorbed and the ionized is excreted. Again, it depends on percentage. So percentage will be decided by the pH. How many of you got it? How many of you got it? Learn the golden rule. What is the golden rule? The golden rule is that the golden rule in pharmacology is that the unionized drug is absorbed by the body. Unionized drug, whether acidic or basic, doesn't matter. The rule is same. Body retain the unionized. Unionized means complete drug. Body loves complete drug. But whenever there is an ionized form, I mean the charges are present. Charges means positive charge or negative charge. It is an ion. See here, negative charge is present. Here, positive charge is present. Charges are present. Okay. So it is an ionized form. Body excreted. Body don't want charges in the body. No. Body do not retain the ions. So it is excreted. Learn this golden rule. Okay. So this is the same thing written in front of you. Unionized form are absorbed from the body and ionized form are excreted from the body. If you understood this rule, now please see. There are two type of drug now. Acidic or basic, weak acid or weak base. Suppose I am taking a weak acidic drug. See, I am having some disease in my body. And for that, you are a doctor. You have prescribed, ma'am, you can take this drug. Your disease will be cured. So I'm saying, okay, doctor, I have purchased the medicine and I'm taking it via oral route. So I'm taking it. It is going inside me. Now, this drug can be weak acid. This drug can be weak base. Some drugs are acid, some are base. You have to learn the list. I will give you a list also. Okay. For example, this drug is acidic. Okay. Now, the rule says that same medium is required for absorption. Acidic drugs are absorbed from acidic medium. And basic drugs are absorbed from basic medium. Please learn the rule. Same pH is required for absorption and opposite pH is required for excretion. Okay, so let me tell you the four statements. What are the four statements? I'm having acidic drug and I'm having basic drug. Weak acid and weak base. I mean, okay, acidic drug. I want its absorption or excretion. And I want its absorption or excretion. Absorption or excretion. You may be thinking, some of you may be thinking, ma'am, we want only absorption, we don't want excretion. ऐसा कुछ लोग सोच रहे होगे. Some of you may be thinking, what do you want in your patient? You are a doctor. I'm your patient. I'm having some disease in my body. I'm coming to you, doctor. I'm having this symptoms. You are saying, ma'am, you have this diagnosis. Take this drug, you will be all right. Okay, you are prescribing me a drug. So I'm taking that drug. Being a doctor, what do you want? You want that drug should be absorbed in me or that drug should be excreted in me? So of course, most of you say, ma'am, I want the drug to be absorbed. Hana, most of you will say that I want the drug to be absorbed. Yes or no? It is not always the case. Now, imagine I'm having poisoning. Imagine a teenage boy, college boy who tried suicidal attempt. okay, who tried suicidal attempt. He had taken 100 sleeping pills together. He want to do the suicide. Maybe some tranquilizers, some sleeping pills, or some of the pills. He have taken a lot of that together. He want to attempt the suicide. Okay, and parents have seen, parents or some caretaker have taken the patient to you. You are a doctor in emergency room, and they want you to save the boy. Of course, they want to save the child. So in that case, what do you want? The drug, he has already taken the 100 sleeping pills. You want that absorbed or you want that excreted? In that case, you want the excretion. In that case, you do not want the absorption. So depending on the scenario, we do not always want absorption. Sometimes we want absorption, sometimes we want excretion. In case of poisoning, we want excretion. Okay, so depending on that, okay, so let me tell you the rule. Acidic drugs are absorbed from acidic medium and basic drugs are absorbed from basic medium. So please learn, for absorption, same medium is required. Acidic drugs are absorbed from acidic medium. Basic drugs are absorbed from basic medium. For absorption, same medium is required. Okay, for excretion, opposite medium is required. You got my point? Acidic drugs are excreted in basic urine and basic drugs are excreted in acidic urine. Got my point? So for excretion, opposite pH is required. Acidic drugs excreted in basic urine. Okay, and basic drugs excreted in acidic urine. For excretion, opposite pH is required. If you learn these 4 lines or understand it, many MCQs based on this. I will show you the MCQs also. First, you give me the thumbs up if you got it. So please, what is the rule? For absorption, same pH required. And for excretion, opposite pH is required. Okay, because acidic drugs in acidic medium, please understand the concept. Now, why? You may be asking, ma'am, why? Why it is like that? Can you give me the answer for why? Yes, I can give you the answer for the why. Listen, acidic drugs in acidic medium remain unionized. Okay, basic medium in basic pH remain unionized. In the same pH, drug remain unionized. Maximum is unionized, and you know unionized form is absorbed. Okay, in opposite pH, drug gets splitted. In opposite pH, drug get ionized. And you know ionized form is excreted. I told you the golden rule. Okay, I told you the golden rule. So this is the complete. You can take a snapshot, you can learn, you can fit in your mind. This is the concept based on which you will get many question. So imagine there is a drug, maybe acidic, maybe basic. I'm not bothered. Maybe it can be an acidic drug, that is HA. It can be a basic drug, that is BUH. Whatever it is, I'm not bothered. Okay, this is a drug. Ultimately, this is a drug. I can say this is a drug. Okay, now if you give the same pH, if it is an acidic drug and you are giving acidic, if it is a basic drug, you are giving basic. I mean, if you are giving the same pH to the drug, so drug will remain in unionized form only. If it is unionized, body will absorb it. It will get absorbed. This is the funda. But if you give the opposite pH, acidic drug, you are giving basic pH. Basic drug, you are giving up acidic pH. The drug split. In opposite pH, the drug cannot withhold. It will ionize. It will ionize in opposite pH. And if it is ionized, body will excrete it. Body don't retain ions. Body don't like ions. Body excrete ions. So this form will be excreted. You can learn that way. Hana, the thing is the same. The concept is the same. You learn like this or you learn like that. The concept remains the same. So this is the final funda. For absorption, same pH is required. And for excretion, opposite pH is required. Please learn the rule. If you understood now, it's very good. If you don't understood, it's double good. You just learn the concept. Okay, I mean learn the 4 lines. Nobody is going to ask you the concept. It's not a subjective exam. It's the MCQ exam. Ultimately, answer should be correct by hook or by crook. If you understood, it's very good. Hana, you apply the concept. If you don't understand, you mug it up. It's okay. But you have to learn it. You can't leave this concept. So please learn. For absorption, same pH is required. And for excretion, opposite pH is required. So acidic drugs are absorbed from acidic medium. And the basic drugs are absorbed from basic medium. Okay, now let's show you the same concept here in this diagram. Now this is a master diagram in which I'm going to teach you complete pharmacology as well as complete pharmacokinetics and dynamics. This is the master diagram. I hope you all understood this diagram. Let me show you here. Listen. Everyone on the screen. This is a drug the patient is taking via oral route. Okay, the drug is going in the mouth, then it is going in the esophagus. Now imagine if the drug is acidic, it will be absorbed from the acidic medium. So acidic drugs are absorbed from stomach. Stomach have an acidic medium. And if the drug is basic drugs are absorbed from basic medium. If the drug is the basic, it will be absorbed from the intestine because intestine have a basic medium. So acidic drugs are absorbed from stomach and basic drugs are absorbed from intestine because we all know stomach have acidic medium and thus intestine have basic medium. You got it? So organ of absorption is different. Acidic drug absorbed from stomach. And basic drugs absorbed from intestine, two different organ. Stomach is a different organ. Intestine is a different organ. So the different drugs, acidic and basic, are absorbed from different organ. This is my stomach, this is my intestine. If I'm taking an acidic drug, it will be absorbed from my stomach. And if I'm taking a basic drug, it will be absorbed from my intestine. Organ is different. Organ hi alag hai. Okay. But for excretion, the organ is same. Both of them are excreted from kidney via urine. Whether it is an acidic drug or basic, first they will go in the blood. After that, they will go at their site of action, show their mechanism of action. This is distribution. After that, they go in the liver. They get converted from non-polar to polar. That is metabolism. Now, both of them, acidic as well as basic, they came to the kidney for excretion. So, organ of excretion is same. It is kidney. But kidney may, what is formed in the kidney? I'm sorry. In the kidney, the urine is formed. The pH of urine can differ. So, if you want to excrete the acidic drug, make the urine basic. If you want to excrete the basic drug, make the urine as acidic. We can change the pH of the urine accordingly, being a doctor. Imagine there is a patient in my clinic and I'm the doctor in emergency room, and the patient is a poisoning patient. The parents are carrying the boy on the stretcher and parents are saying, doctor, my child have taken 100 sleeping pills at one time. He want to commit the suicide. Kindly save him. Save him. At that point, I want the drug to be excreted. I do not want absorption. I want excretion. So the first question I will ask the caretaker, show me this empty strip. Okay, which tablet, which drug, which chemical he have taken. So being a doctor, whenever they are showing, I must know is it an acidic drug or basic drug. It's an emergency. I must know is it an acidic drug or basic drug. If it is an acidic drug, I will make the urine as basic. If it is a basic drug, I will make the urine as acidic so that the drug can be excreted out of the body. We can change the pH of the urine. Now, the next question, how we can change the pH of the urine, ma'am? We can change the pH of the urine. So if you want to make the urine as basic, because you want to excrete acidic drug. If you want to excrete acidic drug, you want to do alkalinization of the urine. So if you want to do the basification or alkalinization of the urine, start IV drip of sodium bicarbonate, NaHCO3, sodium bicarbonate. Start IV drip, via which the urine become basic. And the acidic drug will be excreted out of the body. And if you want to make the urine as acidic, because you want to excrete the basic drug, the poisoning is of basic drug, you want to acidify the urine, again start IV drug. IV. We are starting IV because it's an emergency. We can't give oral. We are starting IV. But this time we are starting 2 IV. First arginine hydrochloride followed by ammonium chloride. Arginine hydrochloride followed by arginine hydrochloride followed by ammonium chloride. So this will acidify the urine. So being a doctor, you can change the pH of the urine of your patient. Don't do opposite. Patient will die. Okay. If the patient have ingested acidic drug, make the urine basic so that it can be excreted. If the patient have ingested basic drug, poisoning of basic drug, make the urine acidic so that it can be excreted. If you are doing opposite, absorption will be more, patient will die. You can't do so. Okay. So this is how you can go ahead. I hope you are getting it. I hope you are getting the concepts behind that. So I hope this page is crystal clear to you. Shall I repeat or you got it? Learn one funda. For absorption of the drug, same pH is required. And for excretion of the drug, opposite pH is required. This is the first rule. You have to learn 2 golden rules. This is the first golden rule. So if we want to absorb an acidic drug, it is absorbed from stomach, and basic drug is absorbed from intestine. If we want to excrete an acidic drug, basic urine is required. Basic pH urine is required. If you want to excrete a basic drug, acidic pH urine is required. We can acidify and basify the urine accordingly. I told you how. This is the first funda. The second funda you have to learn. Body retain, absorb unionized drug. Unionized drug is absorbed by the body. And ions, body do not like charges, the positive charge, the negative charge, ions. No, body excrete ions. Ionized drug is excreted out of the body. So please learn these two golden rules. If you learn these 2 golden rules, your life will be easy based on these questions. Let me show you the questions based on this. Let's solve some questions. The first question is in front of you. Read the question, tell me the answer. Quick, fast. So the question is in front of you. Acetyl salicylate and phenobarbital. You know, acetyl salicylate is aspirin, and phenobarbital. They are better absorbed in the stomach. Why? They are not asking where they are absorbed. They are telling you they are absorbed in the stomach. But you have to tell me the reason why they are absorbed in stomach, not in intestine. Can you read the 4 options and tell me what is the correct answer? Why these 2 drugs are absorbed in stomach? Okay, what is the pH of the stomach? Stomach is having acidic pH. Okay. And for absorption, they are asking for absorption, not for excretion. They want the absorption. In the question, the examiner is asking is for absorption, same pH is required. So it means the drug is also acidic. So these two drugs are weak acids. We are not talking about strong acids. We are talking about weak acids. We are not talking about bases. We are talking about weak acids. So it is clear to me these two drugs are weak acids. That's why they are absorbed from stomach. So these two drugs are weak acids. Okay. These two drugs are weak acids. Now you tell me in gastric pH. Gastric pH means acidic pH. They remain ionic or non-ionic? I mean they are ionized or they are unionized. So body absorb which form? Ionized form or body do not like charges. Body do not like ions. Body do not absorb ionic form. Body absorb anionic form. So that's why the correct answer is A, not B. Some of you are getting confused. The correct answer is A. Body do not absorb iron. Body excrete iron. For absorption, the anionic form is required. So correct answer is A. Give me a thumbs up, everyone. Those who got confused also, please give me a thumbs up. So correct answer is A. The next question is in front of you. Read the question and tell me the answer quickly. Read the question and tell me the answer quickly. So acidic drugs are ionized at which pH? I'm talking about weak acid, weak acidic drug. And I want the ionization. What do you mean by ionization? Ionization means absorption or excretion. You tell me. Absorption or excretion? Body absorb ionized form or excrete? Body do not like charges. Body excrete ionized form. Anna? So we are talking about excretion of acidic drug. So rather than reading the question like acidic drugs are ionized at, you read the question acidic drugs are excreted in which pH? Excretion opposite pH is required. So acidic drugs are excreted in alkaline pH. So correct answer is again A, and you all are right. So this is a way you should approach the question. The approach is important. So based on the concept, you should be able to apply that concept in the question. That's more important. Okay. The next question is in front of you. What is true about acidic drug? So we are talking about weak acids only. The weak acidic drug. So you tell me what is correct. The acidic drugs are best absorbed in the acidic medium, or they are absorbed in alkaline medium, or they are not absorbed in acidic medium, or they bind to alpha-1 glycoprotein. So we know the concept. For absorption, same pH is required. And for excretion, opposite pH is required. I guess everyone knows this concept till now if you're attending the lecture from the beginning. Right? Say, so they are talking about the acidic drug. So acidic drugs are absorbed from acidic medium. They are absorbed from acidic medium. So if we talk about the excretion, if instead of absorption, I say the excretion, so they are excreted in alkaline medium. They are absorbed. Acidic drugs are absorbed in acidic medium and excreted in alkaline medium. I hope you are getting it. Okay. The next question, I guess last question based on this concept is in front of you. After that, we will move on the next topic. The next concept. Read the question and tell me the answer. What is the best way to manage a patient with aspirin poisoning? First, you tell me aspirin is an acidic drug or basic drug. Aspirin is an acidic drug or basic drug? You tell me. So aspirin is an acidic drug. First of all, you must know aspirin is an acidic drug. If you don't know, please learn it. Okay. And now for the main drugs, you must know, is it acidic or basic? I will give you a list. So this is an acidic drug. The first thing. Now patient is in poisoning. You do not want absorption. You want excretion. See the word poisoning. In case of poisoning, we want the drug to be excreted. And for excretion, opposite pH is required. Okay. So this is an acidic drug. You want to excrete it. You want to make urine basic. So how we make the urine basic? What is the method of basification of the urine or alkalinization of the urine? So you can do the alkalinization of the urine via starting the IV drip of sodium bicarbonate. So correct answer is B, and you all are right. You all are right. I hope you got it. Okay. Okay, so can we go ahead? The next topic. The next topic here is the bioavailability. What do you mean by bioavailability? Again, the same master diagram. I told you I will teach you the complete pharmacokinetics as well as dynamics in this diagram. This is my master diagram. Okay. Now see, this is the drug the patient is taking via oral route. Okay. The patient is taking, for example, I'm having fever and I'm taking paracetamol. Okay. Or any drug I'm taking for any particular disease. I am taking 100 gram of the drug. 100 gram tablet. It's going inside me. It will get absorbed. If it is an acidic drug, it's going in my mouth, it's going in my esophagus, it's going in my stomach, and it's going in my intestine. Not depending what drug I have taken. It can be acidic, it can be basic. If it is an acidic drug, it will be absorbed from the stomach. Okay. It is a basic drug. It will be absorbed from the intestine. Okay, we understood this concept. Ultimately, drug reaches in the blood. Yes or no? But how much? How much I have taken? 100 grams. And how much reach in the blood? It is not always 100. It is not always 100. It is less than 100. So maybe it is 70, 80, 90, maybe up to 99, but never 100. Via oral route, 100% absorption is not there. So how much drug reach in the blood? The percentage is known as bioavailability. out of 100%. Out of 100%, if 80 gram is reaching, bioavailability is 80%. Okay, it can be 70%, it can be 50%, it can be 10%, it can be any percent. So it is the percentage or the fraction of the drug out of the total drug administered. How much drug you have administered? 100 grams. So out of the total drug administered, the fraction which is reaching in the circulation, that is bioavailability. So what is bioavailability? Rather than mugging up, please understand the concept. So what is bioavailability? It is the fraction of what? The total administered dose. How much dose you are administering. Here I have told you I am administering 100 grams. So out of the total administered dose, how much is reaching in the blood? How much is reaching in the blood in unchanged form? So how much reaching in the circulation in unchanged form? So you are giving 100 grams. How much grams are reaching in the blood? So bioavailability in oral route is less than 100. But in all the routes, it is less than 100 except IV. What is IV? In IV, we are giving the drug directly in the blood. IV, you are giving it directly in the blood. IV line. You are taking IV line. Drug is given directly in the blood. So whatever, you are giving 100 gram. 100 is reaching in the blood. So for bioavailability, IV route is having 100% bioavailability. 100% bioavailability in IV route. But apart from IV, all other routes have less than 100. It's never 100, it's less than 100. Maybe 90, 80, 70, 60, 50, whatever. But it's never 100. 100% bioavailability only in one route, that is IV route. I hope you are getting it. You'd get question on that. So IV route have 100% bioavailability. IV route. Rest all the routes have less than 100. They have less than 100. Never 100, less than 100. IV route have 100% bioavailability. You learn this concept. Give me a thumbs up. Got it? You got it? Now let's talk about the oral route, because most common route is oral only. We give the drugs via oral route. The most common route is the oral only. Okay, so via oral route, whenever we give the drug is going inside. So bioavailability is not 100. So what are the reasons why the bioavailability is not 100%? There are two reasons. Number one, absorption. And number two, first pass metabolism. Now let me explain you what do you mean by that. So imagine if I am giving 100 gram of the drug to the patient. We are giving 100 gram orally. 100 gram of the drug orally. Okay. Now, so this 100 gram is going inside. So out of 100, how much is absorbed? Absorption may be the reason. Okay. Different absorption. Different people can have different absorption. Some have more absorption. Some have less absorption. So number one reason is absorption. Okay. Out of 100, for example, only 80 is absorbed. So this 80 is going in the blood. This 80. After it goes in the blood, you know, this is the blood vessel of the intestine. This is a blood vessel of the GIT, mesenteric blood vessel. From the blood, it will go, this is a portal blood. From the blood, it will go to the liver. From the portal circulation, the drug will go in the liver. Okay. And liver have the enzymes which will metabolize the drug, which will destroy the drug, metabolize the drug. So out of this 80%, maybe another 20% is metabolized. So only 60% will come in the blood. So bioavailability depends on two factors. What are the two factors? Number one, how much it is absorbed. And number two, the metabolism. The first pass metabolism in the liver via portal circulation. Okay, so whatever drugs we are giving from the GIT, the drugs goes in the liver. In the liver, they get metabolized and then it come in the circulation. Okay, so two reasons are there. Absorption and first pass metabolism. Anyone have any confusion? So these are the two reasons why bioavailability is less than 100% in oral route. It's never 100%. In IV, it's 100%. But in oral, it's less than 100 because of the two factors. What are the two factors here? Number one, absorption. And number two, first pass metabolism in the liver. These are the two factors which are contributing in less than 100% bioavailability. I hope you are getting it. Okay, now how to calculate the bioavailability? You get question, the graph-based question on that. How to calculate the bioavailability? You have to make a graph. So take in a graph, we are having two axes, x-axis and y-axis. Suppose I am taking a drug via oral route. So this is the drug. You take my blood sample right now, as soon as I have taken the drug. So on y-axis, on x-axis, we are taking the time. And on y-axis, we are taking the plasma concentration of the drug. The plasma. Now you take the blood sample and check the plasma concentration. So currently it's 0. Because I have just taken the drug. It's not yet absorbed and gone in my blood. So currently it's 0. But gradually it will increase. The drug will be absorbed. So if it is an acidic drug, it will be absorbed from stomach. If it is a basic drug, it will be absorbed from the intestine. Ultimately, it will be absorbed. So if you check my plasma concentration constantly, every 15 minutes, every 30 minutes, it will increase. It will be a peak. After that, it will go in the kidney. From the blood, the drug will go in the kidney and get excreted in the urine. So gradually, the concentration will fall. And at one time, it will be 0. So for all the drugs, the graph will be like this. Yes or no? This is the graph. This graph is known as the graph between concentration and time. Okay. So concentration and time. So make this graph. So take a graph. There is an x-axis, there is a y-axis. On the y-axis, take the plasma concentration of the drug. And on x-axis, take the time. So obviously, once I take the drug, initially it will be absorb, go in my blood, go in my blood, go in my blood. So concentration will increase. It will be completely absorbed. Maximum it can do. So the concentration will be peak. And after that, it will fall because it is excreted. So first it will increase, then it will decrease, again will become zero. So this graph, you have to calculate the area under this graph. Area. How to calculate the area? It is looking like a triangle. You know the formula of triangle, the area half into base into height. You have read this in mathematics. Whatever is the formula, we are not interested in that. Okay. You have to calculate the area of this. So that will give you the value of bioavailability. That will give you. So how to calculate the bioavailability of a drug? If you want to calculate the bioavailability of the drug, make a graph between plasma concentration and time and calculate the area under that. Can you see the area of this graph? So this is known as AUC, area under curve. What is the full form of AUC? Area under curve. Area under this curve will give you the value of bioavailability. See this curve. Can you see this curve? See this curve. So you are looking on the x-axis, it's time. On the y-axis, it's plasma concentration. So initially the concentration increase, become maximum, then fall, again become zero. So you calculate the area under curve. The area under curve will give you the value of bioavailability. I hope you got it. Now let's compare for the same drug. This is the same drug. I'm having two subjects. I'm having two different patients, two different subject. I'm having same drug. The name of the drug is drug A. So here the drug A, this drug A is given orally. Drug A is given orally. And here the same drug A. This is also drug A. This drug A is given IV. Okay. So here also I'm making this curve. Okay. Here also I'm making this curve. On y-axis, I'm taking the plasma concentration. Here I'm taking the time. Here also I'm taking the plasma concentration. Here also I'm getting the time. So here also I will get a triangle. Initially the concentration increase, then become constant, then fall. Here also I will get a triangle. The concentration will increase, maximum, and then fall. So let's compare the two graphs. The same drug, but the route is different. The drug is same. Please understand. The drug is same. Here also it's drug A only. Here also. The route is different. So here you can see the two curves. Let me show you the two curves. The drug is same. The drug is same. So you calculate the area under curve. This is IV. This is curve for IV. And this is curve for the oral route. Can you see the curve for IV? Where is the curve for IV? This one. The bigger triangle. The bigger triangle. And can you see the curve for oral? The lesser triangle. The smaller triangle, I mean. The smaller triangle. This one. Can you see this? Now, obviously, the area of the bigger one is more than the area of the smaller one. So here we have proven the bioavailability of IV is more as compared to the bioavailability of oral, the same drug. If we give the same drug orally and the same drug IV, the bioavailability will be more in IV because in IV it's 100%. In oral it's never 100. So if you calculate the via area, you will be proven, and you get many MCQs based on this concept. Okay, the concept is important. You get questions. Maybe this graph coming in your exam, they can ask you the route, the two curves. This curve is for which route, this curve is for which route. They can ask you this graph is showing what? It is showing bioavailability. How the bioavailability is calculated in this graph? Via calculating the area. Multiple questions can be framed. Okay, you must be aware of the concept. Give me a thumbs up if you got the concept. क्या concept है यहाँ? पहली बात तो curve किन दो चीजों के बीच में बना रहा है. We are making the curve between what two things? Number one, plasma concentration. Number two, time. This is the first thing you have to learn. Okay, second thing, this curve we are making like this. It will be a triangle. The third thing, we have to calculate the area under the triangle. The area. And the area of this, which is known as area under curve. It is giving the value of bioavailability. So please learn these concepts. And we are comparing the two curves via different routes. And we can compare the bioavailability. Okay, so this is like that. Now coming on the next concept. The next concept is the prodrug. Can I come on the next concept? The next concept here is the prodrug. What do you mean by prodrug? Imagine. Now again see here. Okay. Some drugs, not all. I will give you the list. There are some drugs which are inactive. Whenever we are giving them, they are inactive initially. They are known as prodrug. So just suppose I am taking a prodrug, it's an active drug. So it's going inside me. First it will go in my mouth, then in my esophagus, then in my stomach and intestine. So it's going in the mouth, esophagus, then stomach and intestine. If it's an acidic drug, it will be absorbed from stomach. If it's a basic drug, it will be absorbed from intestine. It's okay. It will absorb and reach the blood, but it's inactive. It's inactive, people. It's inactive. Okay, it's inactive. It cannot go to its site of action and show its mechanism of action. No, it cannot do so because it's inactive. So how it will show its mechanism of action? Suppose this is a drug for migraine headache. So it will go in my cranial blood vessel, but it cannot cure it. It cannot treat it because it is inactive. So first we have to make it active. How we will make it active? So it will go in the liver. Liver have the enzymes that will activate it. Okay, and after getting activate, the active form come in the blood, and from blood it will go its site of action. So these drugs are known as prodrug. They cannot show their mechanism directly. First, they have to go to the liver for getting activated in the body. Then after getting activated, they can show their mechanism of action at their site of action. These drugs are known as prodrugs. These drugs are known as prodrugs. So there is a list. Not all drugs are prodrugs. Most of the drugs are directly active. They are directly active. So once you take it, they will get absorbed. They are active. They are active. They are active in the blood. So they directly go to their site of action and show their mechanism of action. They do not have to go to the liver first. These are not prodrugs. You have to learn the list of the prodrug. How many of you got it? So what's the list of the prodrug? I'm having a mnemonic for you. The mnemonic is all prefer doing MD in clinical subjects. I hope you also prefer doing MD in clinical subjects. Yes, it's a mnemonic. Okay, you have to learn. So here A stands for ACE inhibitors. All ACE inhibitors are prodrug except captopril and lisinopril. Please learn. Except captopril and lisinopril. Okay, captopril and lisinopril. Except these two drugs, all ACE inhibitors are prodrugs. Hannah, you get question on exception. Please learn it. What is ACE inhibitor? The drug which end on the suffix pril. There are many pril, ramipril, many prils are there. So except captopril and lisinopril, all ACE inhibitors are prodrug. Number one. P stand for many things. It can be prednisolone, proton pump inhibitor, proguanil. These are P. D stand for difiveprin. Okay. M stand for three things. It can be mercaptopurine, methyl dopa, and minoxidil. D stand for dopa, levodopa. D for dopa. I stand for irinotecan. C stand for cyclophosphamide, clopidogrel, and carbamazole. And S stand for sulfasalazine. Okay, I hope you know where these drugs belong in which category. Okay, you have to learn this mnemonic. Please learn the list. And you get simple question on that. All of the following are prodrug except like that. Or which of the following is a prodrug? Read it. Okay. Yes, it's a parabola triangle, Hassan. The shape is not important. Maybe it's a parabola triangle. I got it. It's not an exact triangle. But the main concept is that you have to calculate the area for that curve. Whatever is the formula, you have to calculate area. Area under curve will give you the value of bioavailability in that curve. Okay. Can we apply the mnemonic here? The mnemonic is, what is the mnemonic? All prefer doing MD in clinical subjects. This is the mnemonic. Now read the question and tell me the answer. So aspirin is coming. Yes, it's coming. Levodopa, D for dopa, it's coming. Difiveprin, yes, it's coming. But what about captopril? No. All ACE inhibitors are prodrug except captopril and lisinopril. So captopril is an exception. So we are done with this topic also. Can we come on the next topic? Give me a thumbs up. Can we come on the next topic? The next topic is metabolism or biotransformation. Before that, distribution I will show you here only. Everyone on the screen. I told you pharmacokinetics. I'm teaching you what? Start from the beginning. Okay, I'm teaching you pharmacokinetics. Pharmacokinetics have 4 branches. Absorption, distribution, metabolism, and excretion. I already completed absorption. Here I taught you main points. I taught you the effect of pH on the drug. Okay, the absorption of the drug as well as excretion of the drug we have seen. Okay, after that we have seen what is bioavailability, how to calculate it, what is the curve, we have seen all that. After that we have seen the absorption of the prodrug, list of prodrug, we have seen that. Now the next topic is distribution, and after that we will come on metabolism, also known as biotransformation. Metabolism also known as biotransformation. So let me tell you distribution here only. Listen, everyone on the screen, everyone, please concentrate on your gadgets, please. It's a very important concept. Whenever you are taking any drug via oral route, here only, you can see this is a drug we are taking via oral route. Any drug we are taking oral route. Okay, the drug is going in the mouth, in the esophagus, in the stomach and intestine. Drug is getting absorbed. We know the pH. Hana? Same pH is required for absorption. Acidic drug absorbed from acidic medium, basic drug absorbed from basic medium. The drug reach in the blood. Now, when the drug reach in the blood, the drug have 2 forms. Okay, this is known as free drug. Can you see this one is free drug? A portion of the drug will combine with a protein. It is known as bound drug. So in the blood, we have 2 forms of the drug, the free drug and the bound drug. Okay, what is free drug? Free drug is drug itself. which is absorbed. The drug, that's it. No, that's it, nothing else. The drug only. But a proportion of the drug will bind with the protein. You will say, ma'am, which protein? So again, it depends. Acidic drug bind with albumin, and basic drug bind with alpha-1 glycoprotein. So protein can differ. Okay. So here, this is the protein. So a portion, you can see the red color is the drug. So if only drug is there, it's free drug. If the drug is combined with the protein, it's known as bound drug. So we have two forms. Okay. And the proportion can vary. Okay. There is an equilibrium between the two, I mean. There is an equilibrium between the two forms. Okay. You will say, ma'am, why we have two forms over here? Why we have, listen. No, it is the free drug which will move to the site of action and show mechanism of action, not bound. Not bound. Free drug will go. Free drug. After showing mechanism of action, the free drug will move to the liver and get converted from non-polar to polar form. That is showing the metabolism. And is the after the metabolism is over, it is the free drug which will go in the kidney and get excreted out of the body. So it is the free drug which is moving everywhere. Free drug is showing mechanism of action. Free drug is showing metabolism, and free drug is showing excretion. Bound drug neither show mechanism of action, nor show metabolism, nor show excretion. The bound drug. You will say, ma'am, what is the use of bound drug then? Why God has given the bound drug? I mean, why bound drug is there, exist? Why it exists? It is neither showing mechanism of action, nor it is getting metabolized, nor it is getting excreted. Why bound? Bound drug is a backup. Whenever the free drug move here, here, and here, the concentration of free drug fall in the blood. It is moving everywhere. So bound drug is a backup, and it will keep on converting into free. It will keep on converting into the free. When the free drug will fall, bound will convert into free. There is the equilibrium between the two. So you can see the bound is giving a reservoir. It's a reservoir. It's a reservoir. It's a backup. I hope you got it. You get MCQs on that. Simple MCQ. Which of the following is true? Which of the following is false? You must have the concept. It is the free drug which is showing mechanism of action. It is the free drug which is showing metabolism. And it is the free drug which is showing excretion. Bound drug doesn't do anything. Doesn't do. It is only a reservoir. It's only a backup. Okay. Whenever the concentration of the free drug falls in the blood, the bound is giving a backup. I hope you are getting it. Give me a thumbs up. This is distribution. Now coming on metabolism. Okay. Now coming on metabolism. Imagine distribution is done. The free drug already shown the mechanism of action, and the disease is cured. For example, I'm having migraine headache. Okay. I'm not having, but suppose I'm having. For that, I'm coming to you. You are a doctor, no? I'm coming to you. The doctor, I'm having headache. It's a migraine headache. And you are prescribing a drug, some NSAID or some drug. Ma'am, take this drug. You will be all right. Okay. I'm taking that drug via mouth. It's an oral drug. So the drug is going inside. It got absorbed. Whether from stomach or intestine, doesn't matter. It got absorbed depending on the nature of the drug. Okay, it got absorbed. In the blood, it is having free form, it is having bound form. The free form go in my brain, the cranial blood vessel, and it has shown its action, the mechanism of action. And my headache is cured. It is no more required in the body. My headache is cured. Now I want to excrete the drug. I cannot keep the drug throughout my life in my body. No, it has already shown its mechanism of action. The drug has already shown its mechanism of action. Now I want to excrete it out of the body. Yes or no? I want to excrete it. So excretion is done via kidney. So this drug is going to the kidney, the free form only, not bound form. This drug is going to the kidney. Kidney, will you excrete me? My job is done. My responsibility in this body is done. Now I want to get excreted. Can you please excrete me out of the body in the form of the urine? So kidney is saying, no, I cannot excrete you. So drug is asking, why you cannot excrete me? Why you cannot excrete me? I want to get excreted. So kidney is saying that I can excrete only polar drugs. Because urine is water. In the urine, only water soluble drugs can go out, and you are not water soluble. So how can I excrete you? You are a non-polar drug. So before getting excretion, we want to convert the drug from non-polar to polar. Means water insoluble to water soluble. Okay, non-polar to polar means water insoluble. We want to make it water soluble so that it can excrete it out of the body. So before that, the drug is going in the liver and asking the liver, I want to get excreted. But kidney is saying, no, I will not excrete you. So because I'm non-polar, so can you please help me? Can you please convert me from non-polar to polar? If you convert me from non-polar to polar, the kidney will excrete me. I will get excreted out of the body. So can you please do so? Liver is saying, yes, I can do so. Come inside me. No, come inside me. Come inside my cell. I'm having hepatocytes inside me. This is my hepatocyte. Inside my hepatocyte, I'm having enzymes. Okay, the most important enzyme is cytochrome P450. There are many enzymes. So this is the liver. This is the cell of the liver, the hepatocyte, inside which the enzymes are there, mainly the microsomes. Okay, the enzymes will convert this drug from, so my enzymes will convert you from non-polar to polar. You come inside me. We will convert you from non-polar to polar. Once you get converted from non-polar to polar, you again go to the blood. From blood, you go to the kidney. and kidney will excrete you. So the job will be done. Yes. So this step is known as metabolism. So let's start metabolism or biotransformation. The meaning is the same. So what is the definition of metabolism or biotransformation? There are three definitions. I'm teaching you metabolism or biotransformation. The meaning is the same. The first thing, this metabolism or biotransformation takes place in the liver. It takes place in the liver. So let me draw a liver. And now please understand, it is taking place inside the hepatocyte of the liver. So liver is converting a non-polar drug to polar drug. This is metabolism. Okay. Or you can say it is hydrophobic to hydrophilic. What is hydrophobic? Hydro means water. And phobic, phobia kya hota hai? Phobia. Phobic means fear. है ना? This drug is water insoluble. Hydrophobic to hydrophilic. Hydrophobic to hydrophilic. Philic means love. I hope everyone knows it now. Phobia means fear. You know, various people have various phobia. है ना? And philia means love. Okay, so basically water insoluble to water soluble. And you know, water and lipid have inverse relationship. I guess everyone know. Water soluble are lipid insoluble. Lipid soluble are water insoluble. ये तो बचपन से पता है ना. I guess everyone know. So or else you can say lipophilic. Lipophilic drug to lipophobic drug. Lipophilic to lipophobic. I hope you are getting it. This is lipophilic because it was hydrophobic, so lipophilic. So we want to convert it from lipophil. So there are three definitions. Metabolism is what? Metabolism is conversion of non-polar to polar. Metabolism is conversion of hydrophobic to hydrophilic. Or metabolism is conversion of lipophilic to lipophobic. The meaning is the same. The language is different. So you get various options in your exam, but the meaning is the same now. You have to understand the concept behind that. Or in simple words, you say, ma'am, it is water insoluble to water soluble. मुझे तो ये समझ में आता है. Water insoluble. I want to convert water insoluble drug to water soluble. Water, so that it can excreted in the urine, because I know urine is water. Simple thing, urine is water. So any drug which is water soluble can be excreted in the urine. If some drug is water insoluble, how you can excrete it in the urine? It is not soluble in the urine. It will not excrete it in the urine. So if you want to excrete a drug, you have to make it water insoluble to water soluble. And this is metabolism. So you have to convert it from non-polar to polar, or you have to convert it from hydrophobic to hydrophilic, or you have to convert it from lipophilic to lipophobic. Got it? Say yes. How we do so? I will tell you. First, you tell me you got the meaning. You got the definition. You learn all these four definitions. The meaning is the same. This is the definition of metabolism. So let's start metabolism, the biotransformation. You got the meaning. Okay, biotransformation or metabolism. Okay, here we are doing some alteration in the drug so that we can convert it from non-polar to polar. Or we can convert it from lipid soluble to lipid insoluble, or water insoluble to water soluble. The meaning is the same, so that it is excreted. It is not absorbed and it is excreted. This is the funda. So how we do so? There are two mechanisms. There are two types of biotransformation, phase 1, phase 2. I will explain. Phase 1 is functionalization and phase 2 is conjugation. What do you mean by that? What do you mean by that? Now this is a drug. Let me draw the drug with blue color. Okay. And here also is a drug. Here also is a blue color drug. Okay. This is a drug which is non-polar. Let me write down. It's a non-polar drug. Let me write down non-polar. I want to convert it into polar. Okay, so how I can do so? There are two mechanisms. Here I will do it with phase 1. Here I will do it with phase 2. So in phase 1, I will expose certain functional group on the surface of the drug. Maybe hydroxyl ion, maybe ammonia, okay, maybe sulfhydryl group, some functional group. Okay, so that it convert from non-polar to polar. It got converted from non-polar to polar because of exposure of some functional group. So this step, this type of metabolism, this type of biotransformation is known as functionalization. It is exposure of the functional group. Functional groups are exposed. Phase 1. Okay. The second method. In the second method, what I'm doing, I'm combining this drug with something else. I'm combining this drug with another substance. This is an endogenous polar substance. It is present in my body. Endogenous polar substance. It can be methyl group, it can be sulfa group, it can be glucuronic acid, most commonly glucuronic. So it's a polar compound. It's water soluble. It's polar compound. When we combine the two, they two combine with each other. The drug, which is non-polar, and the endogenous polar compound, they combine with each other and they will make a conjugate. So here you can see this is the drug, and here you can see this is the endogenous polar compound. They make a conjugate with each other. Conjugate means couple. They make a couple. This is known as conjugation. So they are making a conjugate, and this conjugate is polar. This conjugate is polar in nature. The assembly is polar in nature. Individually, this was non-polar. Individually, this was polar. When you combine the two, the overall they become polar in nature. So this is how I am converting the drug into polar by conjugating it with something, with some endogenous compound. So this is known as conjugation. So there are two steps. There are two types of metabolism. How many of you got it? There are two types of metabolism or biotransformation, phase 1 and phase 2. What are the two types? Phase 1 and phase 2. Phase 2 is functional group exposure and phase 2 is conjugation. People keep responding now. Give me a thumbs up at least, or say something that you got it or you didn't got it, so that I can remove this page and come on the next page. You got it? Everyone got it? There are two types of metabolism. There are two mechanisms. So step 1, the phase 1 is of 5 types. 1, 2, 3, 4, 5. I will explain what are the 5 types. And phase 2 is of 6 types. 1, 2, 3, 4, 5, 6. So total 11 types of conjugation are there. Here we have 5 types and here we have 6 types. First you understand the meaning. So what are the 5 types? How you expose the functional group? It can be via oxidation. It can be via reduction. It can be via hydrolysis. It can be via cyclization and decyclization. You know cyclization. From a straight compound, we make a benzene group, or from a benzene, we make the straight compound. So cyclization, decyclization. Via these 5 methods, we can expose the functional group. So these are the 5 methods. And what are the 6 methods for conjugation? So there is a mnemonic, triple G SMA. So depending on this endogenous compound, to what endogenous compound you are combining the drug, so that the conjugate become polar. So this endogenous compound can be glucuronide, can be glycine, can be glutathione. So GGG. The endogenous compound can be glucuronide, can be glycine, can be glutathione, can be sulfates, methyl or acetyl group, SMA. So please learn the mnemonic. So what are the two types? No, in both of them, the thing is same. The non-polar drug getting converted to polar. But how? In phase 1, it is exposure of a functional group. And in phase 2, it is via conjugating with the endogenous polar compound. Okay, so this is a 5 type. What are the 5 types? Oxidation, reduction, hydrolysis, cyclization, decyclization. And this is of 6 type, depending on the conjugated compound. Endogenous compound. So it can be triple G SMA. So total 6 type of metabolism is there. What we have learned, let me summarize and pack it. So I am teaching you metabolism, also known as biotransformation. Metabolism and biotransformation means what? It is conversion of non-polar drug to polar drug so that it can be excreted out of the body. We are converting a water insoluble drug to water soluble drug, and this is of 2 type. Phase 1, which is known as functional group exposure, and phase 2, which is known as conjugation. Okay, you understood the mechanism. This one is of 5 type: oxidation, reduction, hydrolysis, cyclization, decyclization. And this one is of 6 type. The 6th type is triple G SMA. It can be glucuronide, glycine, glutathione, sulfyl, methyl and acetyl. So ideally you should know the examples of each of them. Which drug is metabolized by which mechanism. There are examples in each category, but most commonly 99% question comes on acetylation. You have to learn the examples of acetylation. Examples. Examiner always very frequently asks you the question, which of the following drug is metabolized by acetylation. So I'm giving you the examples, the mnemonic of acetylation only. Okay, ideally you should learn all. Maximum drugs are metabolized by glucuronide conjugation. Okay, some of them via acetylation. Maximum question, your MCQs come on acetylation. So this is the list of the drug which are metabolized via acetylation. This is a list of the drug which is metabolized via acetylation. What is the mnemonic? I'm having a mnemonic for that. The mnemonic is CHIPS ABC. What is the mnemonic? The mnemonic is CHIPS ABC. Okay, so what is the full form of CHIPS ABC? C stand for clonazepam, which is one of the sedative. I guess everyone know. H stand for hydralazine, which is one of the antihypertensive drug. Okay, I stand for isoniazid, which is one of the anti-tubercular drug. P stand for procainamide, which is one of the anti-arrhythmic drug. S stand for sulfonamide, which is one of the, Dapsone is also a sulfonamide. A, B, C, ace-butylol, amionone, and B stand for benzocaine, and C stand for caffeine. Caffeine, present in the coffee, it is also considered as a drug. So please learn the full form CHIPS ABC. You get many, believe me, you get many questions based on that. MCQs in your exam. The drugs which are metabolized by acetylation. Now read the question and tell me the answer. Apply the mnemonic. All of the following are metabolized by acetylation except They are asking except. What is the mnemonic? Apply the mnemonic. The mnemonic is CHIPS ABC. What is not coming in this mnemonic? CHIPS ABC. What is not coming? You have to tell me what is not coming. Hydrogen is coming or not coming? Of course it's coming. Isoniazid is coming or not coming? Of course it's coming. But what is P? We have one P. Can you see this P? This P is phenytoin or procanamide. So learning mnemonic is not important, people. The full form of the mnemonic is important. तुमको सिर्फ mnemonic आता है, you know only mnemonic, you will get confused in the exam. What is this P? But you should know the full form. You should know. So this P is procanamide, obviously. This P is procanamide. This is not phenytoin. So correct answer is phenytoin, because you can see this P is procanamide. It is not phenytoin. So please learn the full form. You get many questions, repeatedly questions. So now the most important and difficult topic to understand is the mechanism of metabolism. Can I come on the mechanism? How does the metabolism takes place? With the help of enzymes, microsomal and non-microsomal. Listen, everyone, have a look on this diagram. Everyone on the screen. What I told you, what is metabolism? Say, ma'am, metabolism, you told us it is the conversion of non-polar drug to polar drug. Okay, yes, I told you. So this is a drug present in the blood. It is absorbed and it is present in the blood. It has already shown its mechanism of action. It is no more needed in the body. I want to excrete this drug. But kidney is saying, no, I cannot excrete this drug because this drug is water insoluble. It is non-polar. Make it polar, then I will excrete. So this drug is going and requesting the liver. Liver, can you please convert me from non-polar to polar so that I can excrete it out of the body because I got stuck in the body. I'm a non-polar drug. Hana, kidney is not excreting me. My job is done. I have already shown my mechanism of action. Now I want to get excreted out of the body. Liver, please convert me from non-polar to polar so that I can go out of the body. So liver is saying, yes, dear, yes, I can do so. So come inside me. Okay, come inside my cell. I'm having a cell, the hepatocyte. I'm having the cells. These are known as hepatocyte. This is the nucleus of the hepatocyte. This is the endoplasmic reticulum of the hepatocyte. Inside the endoplasmic reticulum of the hepatocyte, there are enzymes known as microsomal enzymes. So you just come inside the hepatocyte. My microsomal enzymes will convert you from non-polar to polar. These enzymes. Okay, so this is known as microsomal enzymes. So please understand, where are the microsomal enzymes? They are present in the liver. First thing, they are present in the liver, inside the hepatocyte of the liver, in the endoplasmic reticulum of the hepatocyte of the liver. These enzymes are present and it is known as microsomal enzymes. So we are talking about microsomal enzymes which are present in the liver. They will convert the drug from non-polar to polar. But there is a catch. Okay, there is a problem. You will say, ma'am, what is the problem here? What is the problem? The microsomal enzymes can cause the induction and the inhibition of the drug. Okay, that can cause trouble. Let me explain you how. You get many MCQs. Please believe me. It's a very hot topic and you get many MCQs from this topic. Rather than mugging it up, please understand the concept once for all. Once for all, it will be clear in your mind. Listen now. Let me explain you inhibition first and then I will explain you the induction. One by one we will see. So let me start with inhibition. The inhibition. I'm first telling you the inhibition. Then I will come on the induction. Please understand the inhibition. See this diagram. See this diagram. Listen. Imagine I'm a patient. I'm having only one disease. I'm coming to you, doctor. I'm having blah, blah, blah disease. And for that blah, blah, blah disease, you are prescribing me one drug. Madam, you take only one drug, you will be all right. I'm taking only one drug. The name of the drug is drug A. Drug A. This is drug A. I have taken the tablet of drug A. It is absorbed. It has already shown its mechanism of action. Whatever I'm having the trouble, I'm cured. Now this drug want to get excreted, but it will go to the liver for metabolism. Okay, this drug A. So liver will convert it from non-polar to polar. The hepatocyte of the liver. Inside the hepatocyte of the liver, the enzyme, the microsomal enzyme will convert it from non-polar to polar. Once it gets converted to polar, it will get excreted out of the kidney. The things were very simple. You see, ma'am, you told us this story 1,000 times. Why you are telling us again? Okay, the things were very simple, but there is a catch. The catch is that, the problem is that we don't take only one drug generally. I'm a patient, I'm coming to you, you will prescribe me multiple drug A, B, C. For example, I'm having pain also, you are giving me NSAID. I'm having fever also, you are giving me paracetamol. I'm having some infection also, you are giving me some antibiotic. I'm having acidity also, you are giving me some Pantacid or something. So you are giving me a cocktail. You are giving me a cocktail of drugs. You are not giving me one drug. I'm having one A, B, C, D, multiple drugs. So it is not one drug which is going to the liver. It is multiple drugs going to the liver. And that is the point. You have to understand this point here. Now, please understand this diagram. I'm zooming this version. Please understand, I'm zooming this liver on the next page. So on next page, I have drawn only liver, but you must have an overview. This liver is from here. The complete diagram you must understand. So you can see this is liver. This is liver. Can you see this is liver? Yes. This is liver. Inside the liver, appreciate the hepatocyte, the circle. This is a cell. Inside that, appreciate the endoplasmic reticulum. Inside that, see the enzyme, this purple blue color enzyme. This is microsomal enzyme that convert the drug from non-polar to polar inside the liver. You can see inside the liver, this is the enzyme. Now, if we take only one drug, the things were super simple. If we take only one drug, see, this drug is A. This drug is A. Red is A and the green one is B. If we are taking only one drug, A, है ना? So things were very simple. This drug A, the red drug, requesting the liver, can you convert me from non-polar to polar? Liver is saying, yes, yes, dear, come inside me, I will convert you. So this drug is moving inside. So this is the red drug. So microsomal enzyme converted from non-polar to polar. The drug was very happy. It get excreted out of the body. After converting into polar, it get excreted. It go to the kidney. Kidney will excrete it. The drug was very happy. Things were very simple. But now we are not taking one drug A. We are taking two drugs. Imagine we are taking two drugs, A and B. Okay. Here what B is doing? See, the B, the green drug. Can you see this green drug B? It is inhibiting this enzyme. See the minus sign, minus. It is inhibiting this enzyme. This enzyme become non-functional. It's an enzyme inhibitor. I will give you the list. It is an enzyme inhibitor. Imagine you are a doctor, you are giving me two drugs. Ma'am, take A and B. Anna, some doctor is there which is not very good doctor who have not read this concept. And that doctor has given me two drugs together. Ideally, these two drugs never given together. Okay, I will give you the list of A also, B also. Okay, so these two drugs, some bad doctor, not a good doctor have given me together. Ma'am, take this drug, take two. I'm taking them together. Anna, I'm not a medico, imagine. And I'm taking the two drugs. I'm trusting the doctor and taking the two drugs together. So the drug A and B are going inside me. Drug B is an enzyme inhibitor. It is going in my liver and inhibiting this enzyme. Okay, this enzyme become non-functional now. Now drug A is drug A is coming and asking the liver, can you please convert me from non-polar to polar so that I can get excreted out of the body? This time liver is saying, no dear, no, I cannot convert you. So drug is saying, why you can't convert me? Last time you have converted me, why you are saying no? So the liver is saying my enzyme is non-functional. There is another drug in my body, drug B, that have inhibited my enzyme. So I cannot convert you from non-polar to polar. You remain non-polar only. So drug A remain non-polar only. It will not convert into polar. If it is not converted into polar, it will not excrete it out of the body. It will remain in the body only. If it remain in the body only, it will cause toxicity. It will cause toxicity. So if you are giving two drugs together, A and B, out of which one is the inhibitor, the first drug will not get excreted and it will remain in the body and it will cause toxicity. So never give this combination. A is known as substrate drug and B is known as inhibitor drug. So I will give you a list of the substrate drug and inhibitor drug, A and B, red and green. So never give them together. If you give them together, what will happen? What is the consequence if you give them together? Ideally, you shouldn't give them together. Hannah, if you give them together, the substrate drug will cause the toxicity, not the inhibitor. Inhibitor will not cause the toxicity. The substrate drug will cause the toxicity. So ideally, being a good doctor, you should know the list of A, you should know the list of B and try to avoid the combination. But in some certain cases, if it is very necessary to give the combination, there is no alternative option. So give drug A in lower dose. Because if you are giving in normal dose, it is going to cause the toxicity. So drug A ka dose reduce karke do. Ideally, you should avoid the combination. But if you can't avoid, it is necessary to save the patient or alternative is not available. You give this combination, but drug A ka level, you reduce the dose so that it do not cause a toxicity. So being a good doctor, you should know the list. You should know the consequences if you are doing so. So A and B. So avoid this combination. A is known as substrate drug, the red one, and the green one, the B, is known as inhibitor drug. So this is the list. This is a list of A. This is a list of B. This is the red drug, the substrate drug. This is A. This is B. I hope you are getting it. B is the inhibitor. Okay, this is substrate. This is inhibitor. You are getting it. Am I live? No comments. Am I live? Huh? So substrate drug. If you are taking, so I'm having mnemonic for both. The substrate drug mnemonic is CT scan. CT scan, SCAN. C stand for cyclosporin and calcium channel blocker. T stand for tacrolimus. Okay. S stand for statins. You know, cholesterol lowering drugs, statins. C stand for cisapride. A stand for amiodarone. And N stand for Navers. Okay, Navers means protease inhibitors in the anti-HIV treatment, AIDS treatment, HIV treatment. So these are the protease, Navers are there. Okay, so never give these drugs with these. These are the green one, the inhibitors. They inhibit the enzyme so that the A drug will not convert from non-polar to polar. They remain as non-polar only and they will cause the toxicity. So B, what are the inhibitor drug? I'm having a mnemonic for that also. The mnemonic is vitamin K cannot cause enzyme inhibition. V stand for valproate. K stand for ketoconazole. C stand for simantidine. Another C stands for ciprofloxacin. Both of them are antibiotics. I'm sorry. This one is an antibiotic. Okay, you can see. And this is the acidity. We give this drug in acidity. E stands for erythromycin. And I stand for INH. That is anti-TB drug. No? Anti-TB drug. Isoniazid. Okay, you got my point. So never. So imagine a patient who is coming to you whose cholesterol is very high. So you want to put the patient on statin. Okay, you can put. You put the patient on statin. There is no worries. But the same patient is having some infection. And you are giving for the infection ciprofloxacin or erythromycin, or the same patient is having TB, you are giving isoniazid. No, this combination should be avoided. Being a doctor, whenever a patient is coming to you, you should always ask the patient list of all the other medicine the patient is taking. So see that list, see what you are adding, and see this combination is not there. If it is there, look for the alternatives. If you can't see the alternatives, if you are giving them together, what will happen? What is the consequence? This is a substrate drug and this is an inhibitor drug. If you are giving them together, A and B, there will be toxicity of A, not B. So reduce the dose of A if the combination is necessary. I hope you are getting it. I hope. So please learn. So never give CT scan. Never give CT scan with what? With a vitamin K cannot cause enzyme inhibition. Avoid this combination. It's a deadly combination. It's a deadly. Being a good doctor, you should avoid it. You should avoid it. You should see the list of the page. It is not, you have this, take this. You have this, take this. It's not a mechanical job. It's not a mechanical job. You have this problem, take this. You have to see the combination. What is the effect of each of these drugs on the human body? Body is only one. You are giving a cocktail of drug. Take this also, take this. Or what all these drugs are going to do inside. You have to work up that also before prescribing. Okay. If it is necessary to give, if you are giving what's going to happen, there will be toxicity of the substrate drug. There will be toxicity. If it is necessary to give the combination, reduce the dose of these and then give. Okay, G, please learn this funda very clearly. This was all about enzyme inhibition. Now we are coming on enzyme induction. Let's talk about induction. Induction, we will do the reverse. Okay, now see this diagram. Again, we have two drugs, the red and the green. The red is drug A and the green is drug B. Okay, imagine only red is given. Don't look at B. Only red is given. So this red drug is going to the liver. Liver, can you convert me from non-polar to polar, please? I want to get excreted from the body. Liver is saying, yes, dear, I can convert you. Come inside me. My enzyme inside the hepatocyte will do so. So you can see this is the enzyme. Okay, microsomal enzyme present inside the hepatocyte. It will convert this drug from non-polar to polar. The red drug, the A drug, the drug is very happy. The drug got converted. The drug get excreted of the body. The things were super simple, but there is a catch. We are not giving only A. Along with A, we are giving B also. Have a look on the B now. Have a look on the B. This is A and this is B. This time B is an inducer. See, it is plus sign. It is inducing the enzyme, not inhibiting. It is inducing the enzyme. So what is this enzyme? This enzyme will become hyperfunctional. This enzyme will become hyperfunctional. Last time it was inhibitor. This time it is an inducer. It is inducing the enzyme. The enzyme become hyperfunctional. So you will say, ma'am, it's a good thing. It's become hyperfunctional. It will convert more of drug A, non-polar to polar. So very fast, the drug A will get converted from non-polar to polar. What is the problem here? There is also a problem. Listen. Let's talk about drug A. So this is a drug A present in the blood. First, I want the drug A should go at the site of action and show mechanism of action. After that, I want it go to the liver and get converted from non-polar to polar. Once it gets converted to polar, I want it to get excreted out of the kidney. This is the sequence I want. Everyone wants the sequence. First, the drug show mechanism of action. Then it get metabolized and then it get excreted. This is the sequence we want. Now imagine here the enzyme become hyperfunctional because of some other drug B. This enzyme inside the liver become hyperfunctional. So it will convert the drug from non-polar to polar before it shows its mechanism of action. It's hyperfunctional. So as soon as the drug come in the blood, the liver will take it and liver will convert it from non-polar to polar before it shows its mechanism of action, because the enzyme is hyperfunctional. So drug cannot show its mechanism of action. So drug will become ineffective or efficacy of the drug will reduce. Instead of toxicity, last time we were having toxicity. Here we will have opposite of toxicity, that is inefficacy. So you are giving the drug, but it is not causing any cure. It is not showing its mechanism of action. You are getting my point, huh? So avoid these combinations also. So never give drug A with drug B together. I will give you the list. Drug A is same, it's substrate drug, and drug B is not inhibitor, it's an inducer. It's an inducer. Say yes if you got it, huh? Got it. So this is the list. So this is a list of A, this is the list of B. A is same, substrate drug. The mnemonic is same, CT scan. This is a CT scan, but B are inducer. B are inducer. The mnemonic of B is GPRS. cell phone battery dead. GPRS, cell phone battery dead. Please learn it thoroughly. G stand for rhizofulvin. P stand for phenytoin. R stand for rifampicin. S stand for smoking. C stand for carbamazepine. P stand for phenobarbital. Okay, B stand for barbiturate. Barbiturate is phenobarbital is one of the barbiturate only, and D for DDT. So never, never, never give this combination. It's a deadly combination. If you are giving it, these drugs will be ineffective. These drugs, and if the combination is necessary, you cannot avoid it. There is no alternative. So increase the dose of these drugs because they are ineffective. Now increase the dose. Okay, so this is the summary. This is the summary. Summary is in front of you. Okay, this is the substrate drug. Okay, CT scan. You can't give substrate drug with these. You can't give substrate drug with these. Avoid this combination. Never give substrate drug with the inhibitors. Never give the substrate drug with the inducers. Substrate drugs are same. Never give them with this or this. Inhibitors are vitamin K cannot cause enzyme inhibition, and inducers are GPRS, cell phone battery dead. So never do this combination. Never give substrate drugs with the inhibitors. Never give substrate drugs with the inducers. Please have a look on all the drugs the patient is having. If you have this combination, avoid it. Look for some alternative. If you can't see the alternative, what will be the consequence if you are doing so? So if you are giving the substrate drug with the inhibitor, there will be toxicity of the substrate drug. If you are giving with inhibitor. If you are giving the substrate drug with the inducer, there will be inefficacy of the substrate drug. So if the combination cannot be avoided, in case of inhibitor, reduce the dose of the substrate drug. In case of inducer, increase the dose of the substrate drug. So you have to modify the dose of the substrate drug because there is toxicity and inefficacy of the substrate drug, not the inducer, not the inhibitor. I tried my best, at least. Okay, so I'm satisfied that I tried. I don't know whether you got it or you didn't got it, but I tried from the depth of my heart. Yes or no? Say, people, say. If you have doubt, please ask it clearly. Learn the three list. Never give CT scan. Learn the full form of CT scan. The first thing. Never give CT scan. With what? Never give them with inhibitors. And never give them with inducers. What are inhibitors? What are inducers? The inhibitors are vitamin K cannot cause enzyme inhibition. And inducers are GPRS, cell phone battery dead. Now, never give them. So, never give CT scan with this also, with this also. If you are giving CT scan with the inhibitor, there will be toxicity of the substrate drugs. And if you are giving them with inducers, there will be inefficacy of the substrate drugs. This is the summary. Avoid the combination. Now, there is a catch. What is the catch? There is one more catch here. The catch is that here is C, here is C, here is C. And options are mostly from C. And you get confused. So you have to learn the full form. What is the C, C, C? The three C's you have to learn. Okay. So this is simantidine and ciprofloxacin. And this is carbamazepine. So don't get confused. This one is carbamazepine, which is one of the anti-epileptic drug. And this is simantidine, one of the anti-acidity drug, and ciprofloxacin, one of the antibiotic. So please learn all the C. You don't get confused in the exam. Otherwise, so V is valproate, K is ketoconazole, E is erythromycin, I is isoniazid. There is no confusion in that. G is glucofulvin, P is phenytoin, R is rifampicin, S is sulfonamide. You have to learn it. Okay, so there is no confusion in them. But the C are, everywhere. So here C is carbamazepine, and here C is cisapride, and I'm sorry, not C. Here C is simantidine and ciproflox. So please learn it thoroughly. Can I move to the next? Okay. Yes, absolutely right. Absolutely right. Okay, now listen. One more thing I want to tell you here before ending this topic. So the next thing is the Hoffman's elimination. What is Hoffman's elimination? Let me explain you what is Hoffman's elimination. Please, everyone on the screen, listen here. What is Hoffman's elimination? Let me explain you. This is a drug. Okay, this is a drug. It want to get excreted. Okay, it has gone to site of action. It has already shown its mechanism of action. The job is done. Now it want to get excreted of the kidney, but kidney is not excreting it because it is a non-polar drug. So the kidney is saying, I will not excrete you because you are a non-polar drug. First you convert into polar, then come to me, then I will excrete you. So most of the drugs are going to the liver now. They are taking the help of the enzymes present inside the cells of the liver. Enzymes are converting them from non-polar to polar. Most of the drugs are doing. So I told you this mechanism is known as metabolism or biotransformation. In metabolism or biotransformation, the liver enzyme the enzyme present in the hepatocyte of the liver, these enzyme convert the drug from non-polar to polar. Okay, some drugs are very what can I say, Anna, some drugs do not want to take the help of the enzyme. Okay, they do not want to take the help of the enzyme. Okay, they say we will do it of our own, we will not take the help of the enzyme. No, we do not want to take anyone's help. We will do, some people are like that, no, we will do it by own, we will not take anyone's help. It's like that. So there is a drug, only one drug, Hannah. The name of the drug is atropine. Okay, this is an anesthetic drug, atropine. It will say, I will not take the help of the enzyme, I will not take the help of the liver, no help of enzyme to get converted from non-polar to polar. So how it will get converted from non-polar to polar? It is not excreting out of the body, it will convert of its own in the blood. So it will do some changes in its structure, in the three-dimensional structure, spontaneously. In the three-dimensional structure, spontaneously it will do certain changes. Okay, in the structure, stereotypic structure may, so that it convert from non-polar to polar without the help of enzyme. And this is known as Hoffman's elimination. It is done in the blood itself. It will not go in the liver. It will not take the help of the enzyme. This drug will get converted from non-polar to polar in the blood itself by changing its structure. Okay, by changing its structure. And this is known as Hoffman's elimination. Spontaneous rearrangement without the help of enzyme. Hannah, the drug is getting converted from non-polar to polar without help of enzyme, spontaneously by itself. Only one drug do so. Only one drug. That is atropine. It is showing Hoffman's elimination. How many of you got it? How many of you got it? Please learn it. So this is Hoffman's elimination. In the Hoffman's elimination, due to spontaneous rearrangement in the three-dimensional structure of the drug in the blood itself, the drug get converted from non-polar to polar itself without the agency of enzyme. No enzyme required, no liver required, nothing required. Only one drug do so. It is an independent drug. You can say self-dependent is a better word. Some people are there, no, we are self-dependent. We do not want anyone's help. So it's the same drug. It is a self-dependent. The drug say, I will not take the help of the enzyme. I will not take the help of the liver. I will do it by myself. Okay, so it is doing by itself. That is Hoffman's elimination. That is atropine. You get questions on that. So read the question. We are done with this topic, people. Metabolism is done. The last thing is excretion. So this topic will be completed. Okay, we are done with absorption. We are done with distribution. We are done with metabolism. Now, lastly, excretion, I will tell you. So the pharmacokinetics will be done. Then we will come on pharmacodynamics. You people are getting it? Yes or no? So have a look here. Okay, so see, all of the following are enzyme inhibitors except. Which of the following is not enzyme inhibitor? You must know the mnemonic. What is the mnemonic of enzyme inhibitor? Vitamin K cannot cause enzyme inhibition. These are the inhibitors. So which is not coming in this list? What is the mnemonic of inducer? The mnemonic of inducer is GPRS, cell phone battery dead. So you tell me what is not coming in this mnemonic. So ketoconazole, it's coming in this mnemonic. Valproate, it's also coming in this mnemonic. Simantidine, it also coming in this mnemonic. But what about carbamazepine? I told you this C is not carbamazepine. This C is ciprofloxacin. This is carbamazepine. So carbamazepine is an inducer, not inhibitor. So correct answer is carbamazepine. If you know the mnemonics, the things are super simple for you. Okay, if you know the mnemonic. Okay, chalo. Can we go ahead? Huh? So this is how you get the question. You get the question on the mnemonic simply. Which of the following drug is an enzyme inducer? Which of the following is an inducer? Say the mnemonic of inducer. GPRS, cell phone battery dead. What is coming in this mnemonic out of the four options? I guess everyone can see rifampicin. R for rifampicin, it is coming in this mnemonic. The remaining three things are coming in enzyme inhibitor. That is vitamin K cannot cause enzyme inhibition. So here you can see I for isoniazid, K for ketoconazole, and E for erythromycin. So they are enzyme inhibitors, not inducers. So only one of them, rifampicin, is coming. Okay, which of the following is an inhibitor? Cytochrome P450 inhibitor means enzyme. It's enzyme inhibitor. Again, you have to apply the mnemonic of the inhibitor. Vitamin K cannot cause enzyme inhibition. What is coming? I guess two options are correct here. So yes, ketoconazole and isoniazid both are coming. Ketoconazole and isoniazid. The question is incorrect. Hannah, in your exam, you will get one of the option. But the main thing, you should know the mnemonic. You should know the mnemonic. The remaining two of them are inducer. So this is how we can go. What is Hoffman's elimination? Can you tell me what is Hoffman's elimination? What is Hoffman's elimination? Read the four options. I told you, the self-dependent drugs. So what is Hoffman's elimination? It is inactivation of the drug by metabolizing enzymes. It is taking the use of enzyme. It is unchanged excretion by the kidney. Or is it is excretion in the feces, or it is inactivation by molecular rearrangement. What is the correct answer? Yes, by molecular rearrangement, spontaneous, three-dimensional molecular rearrangement, the drug is getting converted from non-polar to polar by itself. By itself. So that is spontaneous rearrangement. That is Hoffman's elimination. Okay, so I hope you got it. The last thing is the excretion. So again, the same master diagram. We have done the absorption, we have done the distribution, we have done the metabolism. Now it's time to do the excretion. Let's start the story again and let me come on the last topic, excretion, which is the most difficult out of all these. So please pay attention. See, so this is an oral drug taken. The drug is taken orally for some disease. I'm having some disease. You are a doctor. You have prescribed some drug. Ma'am, take this drug. You will be all right. I'm taking the drug orally. The drug is going in my mouth. Okay, this is the mouth. It is going in my esophagus. Okay, it is going in my stomach and intestine. Stomach and intestine. If it is an acidic drug, if I'm taking, it will be absorbed from the stomach. If it is a basic drug, it will be absorbed from the intestine. Okay, same pH is required for absorption. Acidic drugs absorb from acidic medium. Basic drugs are absorbed from basic medium. Absorption is over. Whatever drug you have given me, I have taken it, it get absorbed, depending the nature of the drug. Acidic or basic, it got absorbed. It reach in the blood. Okay, so absorption is over. Now in the blood, some of the drug is free and some of the drug in equilibrium bound with the protein. The protein can be albumin if it is an acidic drug and alpha-1 glycoprotein if it is a basic drug. We are revising. Okay, so this is distribution. Okay, so some of the drug is free, some of the drug is bound, and there is an equilibrium between the two. The free drug will go its site of action, and on the site of action it will show its mechanism of action. Suppose I am having diarrhea or I am having constipation and I'm coming to you, doctor, I'm having a problem, diarrhea or constipation. So you are prescribing a drug for that. Okay, so the site of action of this drug is my intestine. So I will take the drug, it will get absorbed from the blood, it will go everywhere, but the receptor for the drug is present in the intestine. So the site of action is the intestine. Suppose I'm having heart failure, so you are giving a drug for that. So from the blood, the drug is supposed to go on the heart and act on the heart. Suppose I'm having headache, it should go in the brain. So site of action depends where the receptor of that drug is there. Okay, so based on the receptor of the drug. Okay, in the pharmacodynamics, I will deal with the receptors. So it will show its mechanism of action. This is known as distribution. So absorption is done, distribution is done. Absorption is done, distribution is done. Okay, now after it, the mechanism of action is done. Okay, now the job is done. We want to excrete the drug, but we cannot excrete it directly in the urine. Okay, because urine is water. Only water soluble polar drugs will get excreted, but this drug is non-polar. So first this drug will go in the liver. In the liver, it will convert from non-polar to polar. So conversion of drug from non-polar to polar inside the liver is known as metabolism. Now the drug is finally polar and it is coming in the kidney for excretion. So let's start excretion. Excretion is passage of the drug out of the body. The last step, excretion. So absorption is done, distribution is done, metabolism is done, and finally excretion. Now drug will get excreted. It is already polar. It's already converted from non-polar to polar in the liver. The drug is already converted from non-polar to polar in the liver. It's already polar now. Now we want to excrete it. Say, ma'am, it's very simple. Yes. So let me tell you how does it occur. Okay. Now this organ is kidney. This is kidney. You can see this is the organ of excretion. Most of the time the organ of excretion is kidney only. Okay. In the kidney, this is afferent arteriole. Afferent arteriole. And this is efferent arteriole. Efferent arteriole. And this is urethra. You can see this is urethra from which the urine is coming out. Urethra, you can see. Okay, so you can see the concentration of the drug in the blood in the afferent arteriole. It's 10 microgram. 10 microgram of drug is coming in the kidney. Okay, out of which 500 microgram per minute is excreted. Now the remaining drug will come in the efferent arteriole. So every time when the drug is coming to the kidney, a little bit is excreted in the urine, the remaining will go. Again, it will come. Again, a little bit is excreted, again it will go. Again, it will come, again a little bit will be excreted and it will go. So it will require multiple cycles. It is not in one shot the drug is excreted out of the kidney in the urine. So every time in every passage when the blood is coming via afferent arteriole, a little bit of the drug is excreted out in the urine and the remaining will go, and after going in the heart, and it will come back via aorta, via the renal artery. Say yes if you got it. Huh? Anyone have any problem? Can we go ahead? Huh? So this is how the things go. So this is known as rate of elimination. What is rate of elimination? It is the amount of drug which is eliminated per unit time. In 1 minute, in 1 second or 1 hour. Per unit time, how much drug is excreted out of the kidney? Excreted out of the kidney, that is known as rate of elimination. We write it like R. Rate of elimination is how much drug is eliminated per minute. In 1 minute, how much drug is coming out of the body in the urine. Okay, that is. Now, please understand the concept of the clearance. Please understand the concept of the clearance. It's difficult. Please see. So what I told you, this is afferent arteriole. and this is efferent arteriole, and this is urine. I told you this is urine. You can see this is urine. So the drug is coming out of the urine. So from afferent arteriole, the drug is going in the kidney. A little bit of it the kidney is excreting, and the remaining is going in the efferent arteriole. Okay. So how much is excreted via kidney is rate of elimination. It depends on rate of elimination. Per minute, how much is excreted. So imagine in the afferent arteriole, how much drug is present? 10 microgram per ml. 1 ml of the plasma. 1 ml of the plasma contain 10 microgram of the drug. Okay. Now this much is excreted out. This much. And whatever is left, it is going in the efferent arteriole. Okay. So whenever this much is excreted out, this much is excreted out. So a little bit of the plasma, we have 5 liter of plasma. We all have 5 liter. So out of the 5 liter of plasma, a few ml of the plasma is free of drug. That is known as clearance. Clearance is the amount of plasma which is free of drug, which is completely free of drug. Okay, amount of plasma, how much ml of the plasma is free of drug out of the 5 liter. Out of the 5 liter, that is clearance. So every time when the drug is coming via afferent arteriole, a little bit of drug is excreted out. So a little bit of plasma is free of drug. And again, the remaining will go in the efferent arteriole. Now that will come in the next time. The next time when it is coming, again a little bit excreted out. So a little bit, again plasma will get cleared. And again it will go. So it will go on gradually. The cycles are repeated. One time will come when 100% plasma is free. All the drug is excreted out of the body. How many of you got it? हाँ समझ में आ रहा है? How many of you got it? अच्छा, how many of you didn't got it? Let me ask you the reverse question. Anyone who didn't got it? So that is the meaning of the clearance. So what is clearance? It is the amount of the plasma that is completely 100% free of the drug. Okay, so how you calculate the clearance? How to calculate the clearance? So clearance is calculated by a formula. The clearance is equal to rate of elimination upon plasma concentration, R upon PC. So what is the rate of elimination here? See, the rate of elimination is 500 microgram per minute. Write down 500 microgram per minute upon, what is the plasma concentration? It's 10 microgram. 10 microgram. So you calculate, it is 550 ml. So every time 50 ml out of 5 liter, 5000 ml. 5000 plasma I'm having. How much plasma I'm having? We all have 5000 ml of plasma. Okay. So if I'm taking a drug, every time 50 ml of plasma is cleared. So how many cycles are required to excrete the complete drug? You can calculate 100 cycles are required. So this drug should come to the kidney 100 times. 100, 1, 2, 3, 4. Every time 50 ml, 50 ml, 50 ml, 50 ml, 50 ml, 50 ml, 50 ml. So 100 times it will be 5000 ml. So 100% plasma will be free. This is known as clearance. This is known as clearance. So okay, if you got it, very good. If you don't got it, now don't bother. Double good. You just learn the formula of clearance. What is clearance? What is clearance? Clearance is rate of elimination upon plasma concentration. Shashank, Shekhar. So the meaning of the clearance is, यानी जब drug एक बार kidney में जाती है, when the drug is going one time to the kidney via afferent arteriole, the drug is entering. A little bit of drug is excreted out of the urine and remaining is coming in the efferent arteriole. तो एक बार कितना ml plasma free होता है? क्योंकि थोड़ा सा drug urine में excrete हो रहा है ना? हमारे पास 5 लीटर ब्लड है, 5 लीटर प्लाज्मा है. इफ आई एम टेकिंग अ ड्रग, सो कंप्लीट प्लाज्मा आफ्टर एब्जॉर्प्शन द ड्रग इज प्रेजेंट यूनिफॉर्मली इन कंप्लीट प्लाज्मा. मेरे 5 के 5 लीटर में ड्रग प्रेजेंट है. अब ब्लड जा रहा है किडनी में. इन द किडनी इट इज गोइंग एंड इज एक्सक्रीटेड इन द यूरिन. अ लिटिल बिट इज कमिंग इन द यूरिन every time. So उसकी वजह से कितना ml plasma clear होता जा रहा है. That is known as clearance. Please learn the formula. The formula of the clearance is equal to rate of elimination upon plasma concentration. Please learn it. I hope you got it. This is clearance. I hope you all got the clearance. Now, the last thing I want to teach you here is the order of kinetics. It's something very unique, something difficult you have to understand. Okay. So coming on the order of kinetics. What is order of kinetics? Please learn the formula. I hope you all have read chemistry in your 8th or 9th standard. I guess in my syllabus, it was in 9th standard in my school. In CBSE syllabus. So in the school, in the 9th standard, in the chemistry, we have read the order of kinetics. पढ़ा है कि नहीं? I guess सबने पढ़ा है. We all have read it. There is a formula of order of kinetics is rate of elimination is directly proportional to plasma concentration to the power order. Please learn this formula, to the power order. So rate of elimination is directly proportional to plasma concentration of the drug to the power order of kinetics. You will say, ma'am, what is order of kinetics? I forgot the chemistry. It's okay. I will teach you again. Don't worry. So drugs follow 2 orders, either 0 order kinetics or first order. There are many orders, 0 order, first order, second order, third order. There are many orders. Different chemical follow different. But currently, I'm not teaching you chemistry. I'm teaching you pharmacology. I'm not teaching you chemistry. Okay. I'm teaching you pharmacology. In the pharmacology, it's a study of drugs. So whatever drugs we are taking, they follow two order. Some drugs follow zero order kinetics, some drug follow first order kinetics. So I will teach you these two orders, zero order and first order. So once I will apply 0 here and once I will apply 1 here. That's it. The formula is same. Hana? Instead of order, first apply 0 and instead of order, apply the 1. You yourself find the result. You yourself will find the result. So let's do it. Let's do it. So what is the formula? Learn the basic formula. Rate of elimination is directly proportional to what? It's directly proportional to plasma concentration to the power order of kinetics. Apply this formula. First apply it for the 0 order and then apply it for the first order. So here we are applying it for 0 order and here we are applying it for the first order. So apply the word 0 here. So rate of elimination is directly proportional to plasma concentration to the power 0. Anything to the power 0 is 1. In the mathematics we have read it now. Anything to the power 0 is 1. So rate of elimination is directly proportional to 1. 1 means constant. So basically rate of elimination is constant. Rate of elimination is constant. In 0 order, the rate of elimination is constant. Okay, now apply the first order. Apply the same formula. Same formula for the first order. So rate of elimination is directly proportional to the plasma concentration to the power 1. It's to the power 1. Okay, so here the rate of elimination is directly proportional to plasma concentration. If you increase the plasma concentration, rate of elimination will increase. If you decrease the plasma concentration, rate of elimination will decrease. That is the meaning of directly proportional. Directly proportional. It's not inversely proportional, it's directly proportional. Here, whatever is the plasma concentration, you increase or decrease, rate of elimination is going to be constant. It will not change. You will say, ma'am, it's okay, all these chemistry, all these mathematics, it's okay, ma'am, but I'm not a chemist. Hana, I am a doctor. How it is related to me for my patient? You may be thinking like that. I also think like that when I read all these. I think being a doctor, how it is related to me, whether my drug is following the 0 order or first order. I'm a doctor. There is a patient in front of me. Hana, patient is having blah, blah, blah complaint. Okay, blah, blah, blah disease, for which I'm doing the diagnosis and I'm prescribing certain drug to my patient. Ki Mr., Mrs., whatever, take this drug, you will be all right. Now, this drug follow which order? 0 or first? That matters for me and that matters for the patient. You say, ma'am, how it matters for you and for the patient? Whether the drug is following 0 order or whether this drug I am prescribing to my patient is following first order. Does it matter? Yes, it matters. Let me explain you how. Let me explain you how. Listen, let's talk about them one by one. 0 order kinetics. What I told you for the 0 order kinetics. 0 order kinetics, rate of elimination is directly proportional to plasma concentration to the power 0. Anything to the power 0 is 1. So basically rate of elimination is constant. Rate of elimination is constant. ये sentence को जरा गौर फरमाओ, जरा ध्यान दो. Listen this diagram. Can you see this diagram? Of course. It's a kidney. Okay, this is afferent arteriole. This is efferent arteriole. Blood is going in the afferent arteriole. This is urine. This is urine coming out of the kidney and whatever remaining is going in the efferent arteriole. So blood is coming, it contains the drug. A little bit is excreted out and the remaining will go in the efferent arteriole. You got it? Now imagine the concentration in the afferent arteriole. See the concentration of the drug in the afferent arteriole. It's 10 milligram per ml. Okay, if it is 10 milligram per ml, 1 milligram per minute is excreted. You say, okay ma'am, the blood have 10 milligram. In 1 minute, 1 milligram is excreted. Per minute, 1 milligram. Okay, the rate of elimination is okay. So what if I do it 100 milligram in the plasma? Instead of 10, if it is 100, if it is 1000, if it is 10,000, it is 1 lakh. So what will be the effect on rate of elimination? My question to you. I'm asking you the question. I'm asking you the question. You're getting my point. I'm increasing the plasma concentration. When the plasma concentration is 10, the rate of elimination is 1. है ना, मेरे ब्लड में 10 मिलीग्राम पर ml ड्रग प्रेजेंट है तो मेरे यूरिन में हर मिनट में 1 मिलीग्राम एक्सक्रीट हो रहा है ना. व्हेन माय प्लाज्मा कंटेन 10 milligram, 1 milligram is excreted per minute in the urine. But what if my plasma contain 100, not 10? What if my plasma contain 1000, 10,000, 1 lakh? So what is the rate of excretion? I'm asking you. Can anyone answer? When plasma contain 10, the rate of elimination is 1 milligram per minute. When plasma contain 100 or 1000 or 10,000, what is the rate of elimination? I'm asking you the question mark. Can you answer? It's constant. Absolutely right, Nagma. Absolutely right. It's constant. It's 1. It's 1. It's 1 only every time. So whether the blood contain 10 milligram, 100 milligram, 1000 milligram, 10,000 milligram, kidney is adial. I call this kidney, you understand Hindi? Adial. Very ziddi. Adial. It's stuck. You know, it's very stubborn that I will excrete only 1. Whatever is the plasma concentration. Plasma में 10 है, 100 है, 1000 है, 10,000 है, 1 lakh है, 1 crore है. Doesn't matter. Kidney excrete 1 milligram per minute. It's a adial kidney. It's a stubborn kidney. It's a zero order kinetic kidney. Okay, so if suppose I'm a doctor and I'm prescribing some drug to my patient in particular concentration, take one tablet, half tablet, okay, I'm giving it. Now patients are very smart now, especially Indian patients, है ना? They're taking the drug, they are not feeling well, so don't ask the doctor, let's double the dose, but without asking us they just increase the concentration. Sometimes it happens with some patient who are not very aware of all these things. Now suppose I'm giving it in the concentration of the 10, because I'm supposing 1 will be excreted and the remaining 9 will be there. I'm doing this calculation and prescribing my patient. But without asking me, my patient have increased the dose by himself or herself. He's a very smart patient. He think he's smart, he or she. And he has increased the dose from 10 to 100 by itself, by herself. And it was a zero order kinetic drug. Oh my God. And now 100, the plasma concentration is 100. Still kidney is excreting only 1. And the remaining 99 is present, it will cause the toxicity. Instead of 9, it's 99 in the blood, that will cause the toxicity. So zero order drugs are very dangerous. They are very dangerous. They will accumulate if you increase the concentration, because the excretion is constant. Whether the plasma concentration is 10 or 100 or 1000, kidney excrete only 1. Okay, so if it is 10, okay, so 9 is present, 1 is excreted, still 9 is present. But if it is 100, 1000, it will be 99, 999, like that. It will accumulate. Got it? Say yes. So this is zero order kinetics. This is the meaning of zero order kinetics. So what we have learned in zero order kinetics, whatever is the plasma concentration, 10, 100, 1000, 10,000, 1 lakh, excretion is constant. Rate of elimination, rate of excretion is constant, number 1. A constant amount of drug. I will say constant amount. Constant amount of the drug is excreted every time. It's 1 milligram. It's not always 1 is an example. It's constant amount of the drug. So number 1, rate of elimination is constant. It is independent of plasma concentration, whatever is the plasma concentration. Number 2, constant amount of drug is excreted every time. Constant amount. Every time it's 1 milligram per minute, 1 milligram per, whatever is the plasma concentration. And what about the clearance? What's the formula of the clearance? Clearance is rate upon plasma concentration. Rate is constant. Now, if you increase the plasma concentration, clearance will fall. And if you decrease the plasma concentration, clearance will increase. So clearance is inversely proportional to plasma concentration. The rate is constant. So this is for zero order kinetics. The same I will tell you for the first. Let me summarize the zero. So we are done with zero order kinetics, and now I will tell you first order kinetics. In the zero order kinetics, comment on rate, comment on clearance, and comment on constant what. So say ma'am, rate is constant here. Rate is independent of plasma concentration. We have seen. The clearance is inversely proportional to plasma concentration. Okay, and here a constant amount of drug is excreted every time. Now the 3 things I will tell you for the first order kinetics, they will reverse. Let me explain you the first order kinetics, then I will tell you this table again. Let's come on the first order kinetics. So in this formula, the same formula, can you see the formula? Instead of order, you put the value 1. So rate of elimination is directly proportional to plasma concentration to the power 1. I mean, rate of elimination is directly proportional to plasma concentration. मतलब क्या है इसका? Rate of elimination is directly proportional to plasma concentration. You increase plasma concentration, rate of elimination will increase. You reduce plasma concentration, rate of elimination will fall. That is the meaning. What do you mean by that? Again, the same example, same. Come. So plasma concentration is 10, but urine is excreting 1 milligram per minute. When the plasma contains 10 milligram of the drug, urine is excreting 1 milligram per minute. What if the plasma contains 100? What if the plasma contains 1000? What if the plasma contains 10,000? What is the rate of elimination? When the plasma contains 10, the rate of elimination is 1. Okay, here rate of elimination is directly proportional to plasma concentration. When it is 10, it is 1. When it is 100, it will be 10. When it is 1000, it will be 100. When it is 10,000, it will be 1000. It is 1/10. I say it's 1/10. 1/10 is excreted every time. 1/10. So when it is 10, 1 milligram is excreted. When it is 100, 10 milligram is excreted. When it is 1000, 100 milligram is excreted, like that. So 1/10 is excreted. A constant fraction is excreted, not constant amount. You are getting my point? A constant fraction is excreted. You are getting my point? So constant fraction is excreted. So here a constant fraction of the drug is excreted every time. And what is the clearance? What is the clearance? What is the formula of clearance? Clearance is rate of elimination upon plasma concentration. Here both are increasing. Now both are directly proportional. If you are increasing this, this is also increasing. If you are decreasing this, this is, so they will cancel each out. So here clearance is constant. This is the reason the clearance is constant. So here clearance is constant. If you got it now, it's good. If you didn't got it now, don't take load, just learn the things. No. Broadly you got it. But if you are still confused, don't worry. You just learn the comparative table. So what are the two order of kinetics? People, say with me. What are the two order of kinetics? we are having two order of kinetics, the zero order kinetics and the first order kinetics. Okay, now tell me the summary of both of them. In zero order kinetics, rate of elimination is what? Tell me, clearance is what in both of them? Here rate of elimination is constant. Here rate of elimination is directly proportional to plasma concentration. Okay, this is about the rate of clearance. What about rate of elimination? What about clearance? Here clearance is inversely proportional to plasma concentration. But here clearance is constant because they will cancel each out, both the things. And what the third thing? The third thing, here a constant amount of drug is excreted every time. And here a constant fraction of drug excreted every time. Let me explain this. Okay, in our example, the plasma contained 10 milligram and the urine was excreting 1 milligram per minute. So here, whatever is the plasma concentration, 10, 100, 1000, 10,000, it was always 1 excreted in the urine. So it was a constant amount, 1 milligram per minute is excreted. But here, when the plasma concentration is 10, the 1/10 of that is excreted, that is 1. When the plasma concentration is 100, the 1/10 of that, that is 10 is excreted. When the plasma concentration is 1000, the 100, so 1/10 is excreted. So constant fraction is excreted every time. So I hope I tried my best. I tried my best, whatever best I can explain you. I don't know whether you got it or not. Yes or no? So which drugs are safe relatively? So relatively, first order kinetics is safe. First order kinetics, these are the relatively safe drugs. And these are relatively unsafe drugs because they accumulate in the body. Because the rate of elimination is constant. If you increase the dose, kidney is still excreting 1. From 10 to 100 to 1000, kidney excrete 1. But here the rate of elimination will also increase according to the plasma concentration. So these are unsafe. So you have to learn the list of zero order. First you learn this, you get true false statements on this. Please you learn this. Everyone give me a thumbs up or ask your question. Do one thing. Either say that you got it, give me a thumbs up, or ask your query. Hannah, you may be in one of the category. Either you got it or you didn't got it. So you got it or you didn't got it. Anyone? Yes, I'm waiting for your response. Say something. So let's move ahead. Let's move ahead. Okay. So this is the two order kinetics you have seen. Zero order and first order we have seen. Okay, everyone. Now I will give you a list of the zero order. Except these, the remaining are all the drugs are first order. Zero order are very less drug. You have to learn their examples. You got it, Hannah? I shall explain you again. So this is zero order kinetics. Have a look here. This is zero order kinetics. This is first order kinetics. Compare. So here I am doing from 10 to 100, 1000, 10,000 like this. And here also I am doing from 10 concentration to 100, 1000, 10,000. We are increasing the plasma concentration. What's the rate of elimination? Here rate of elimination currently is 1. When the concentration is 100, it's again 1. When the concentration is 1000, it's 1. When the 10,000, it's 1. It's always 1. It's constant amount which is excreted every time. Rate of elimination is constant. Here rate of elimination is directly proportional to the plasma concentration. When it is 10, it's 1. When it is 100, it will be 10. When it's 1000, it will be 100. When it's 10,000, it will be 1000. 1/10 is excreted. A constant fraction is excreted. So here a constant amount is excreted and here a constant fraction is excreted. So I tried my best to explain you. Okay, now I will give you a mnemonic for the zero order. You have to learn zero order. They are very dangerous drugs. They will accumulate in the body if the dose is increased. So coming on the zero order kinetics. Zero order kinetics. There are 5 drugs which show zero order kinetics. I'm having a mnemonic. The mnemonic is 0 watt, W-A-T-T watt power. You know the unit of the power is watt. In physics you have learned that. The unit of power is watt. So W-A-T-T. Watt power. So 0 watt power. So W stand for warfarin, A stand for alcohol and aspirin. Okay. 1 T stand for theophylline, 1 T stand for tolbutamide, and P stand for phenytoin. Please learn it. Alcohol also comes here. Alcohol, please. Alcohol follows zero order kinetics. Learn that it accumulates in the body. So 1 A is alcohol. So please learn the full form. 0 watt, W-A-T-T power. So warfarin, alcohol, aspirin, theophylline, tolbutamide, and phenytoin. Please learn. They all follow zero order kinetics. The constant amount of drug is excreted. I hope you got it. Can we move to the next topic? Can we move to the next topic? Okay. So this is the order of kinetics. We will solve some questions based on that. After that, we will move to the next topic. Read the question and tell me the answer. What is true about zero order kinetics? Which of the following is true about zero order kinetics? Can you tell me? Which of the following is true about zero order kinetics? Yes. Which of the following is true about zero order kinetics? Yes. So the options are rate of elimination is independent of plasma concentration, or rate of elimination is dependent on plasma concentration. For zero order, the rate of elimination is directly proportional to plasma concentration to the power 0. So rate of elimination is independent of plasma concentration. Option A is correct. I hope you all got it. This is true for first order. Okay, not for zero order. Okay, so we are done with pharmacokinetics. I told you all 4 things in detail: absorption, distribution, metabolism, and excretion. And now we are starting pharmacodynamics. How many of you are ready? Can we start pharmacodynamics quickly? Let's start it. So let's start pharmacodynamics quickly. Let's come. So I'm teaching you pharmacodynamics. We have already seen what the body does on the drug, how body is absorbing, distributing, metabolizing, and excreting the drug. Now we will see what the drug does on the body, what the drug is doing on the body. So here the drug is already present in the blood. How it is absorbed, you know that. It is present in the blood. From the blood, it will go to its site of action and show its mechanism of action. So I'm teaching you how the drug is showing its mechanism of action. So on the site of action, the drug is having its receptors. Drug is binding with the receptor and then going inside the cell of the site of organ. Okay, the site of organ can be different. It can be brain, intestine, heart. It can be any organ depending on my disease. Whatever disease I'm having, you are a doctor, you are prescribing a drug. Ma'am, take this drug, your disease will be all right. Now depending my disease is diarrhea or constipation, so this organ is intestine. My disease is headache, so this organ is brain. I'm having some heart problem, brady or tachycardia, the organ is going to be heart. So this organ differ from disease. Okay, so when the drug is present in the blood, from the blood, the drug goes to its site of action depending on its receptor. So we are studying now pharmacodynamics, the effect of the drug on the body. Okay, so now please understand the receptors. All the receptors have 2 properties. What are the 2 properties the receptors have? Affinity and intrinsic activity. Intrinsic activity is IA. Affinity and intrinsic activity. What do you mean by that? What do you mean by that? Listen, this is a cell membrane. Let me draw a cell membrane. Just a second. Imagine this is a cell membrane. On the cell membrane, this is a receptor. Okay, this is a receptor present on the cell membrane of a cell. This is a receptor. Okay, and this is a drug. This is a drug present in the blood coming on the receptor. Okay, so first the drug will come and bind with the receptor. See what word I'm using. I'm using the word binding. Binding. Of course, there will be a binding. Binding means affinity. Affinity means binding of the drug with the receptor. Affinity. Affinity means binding, जुड़ना, हिंदी में आके attachment होना. So attachment of the drug with the receptor is known as affinity. So what is affinity? Affinity is the binding of the drug with the receptor. That is affinity. So the drug want to show its action, so first it should bind, then it will show its action. So this is the drug. You can see this is a drug coming and binding on the receptor. So this is known as affinity. After affinity, so this is again the cell membrane. On the cell membrane, this is again the receptor. Okay, and this is the drug. Drug first came and bind. Okay, here the drug is binding. So affinity is there. Of course, affinity is there. After that, it will activate the receptor. The activation of the receptor is known as intrinsic activity. So first binding is there, and after binding, activation of the receptor. Activity on the receptor. Activation or activity on the receptor is there. So binding is known as affinity. Affinity. And activation of the receptor is known as intrinsic activity. Okay, so this receptor is having affinity as well as intrinsic activity for the drug. So receptor is binding with the drug as well as receptor got activated with the drug. So the receptor is having 2 properties. So intrinsic activity. What is intrinsic activity? After binding with the receptor, ability of the drug to activate the receptor is known as intrinsic activity. How many of you got it? How many of you got it? So there are 2 things. First, the drug is coming and binding with the receptor. Here you can see the receptor. Can you see the receptor? This is the receptor. So first the drug is coming and binding with the receptor, and after binding it is activating the receptor. So first it is affinity, then there is intrinsic activity. So please understand affinity and intrinsic activity very clearly. Affinity is the ability of the drug to bind with receptor. Bind with receptor. And intrinsic activity is the ability of the drug to activate the receptor. So please understand the definition. Now, based on intrinsic activity, we divide the drugs into 4 categories. There are 4 types of drugs based on intrinsic activity. Let me tell you, based on the intrinsic activity, there are 4 types of drugs. There are some drugs which are known as agonist. Some drugs are known as partial agonist. Some drugs are known as antagonist. And some drugs are known as inverse agonist. agonist, partial agonist, inverse agonist, and one is antagonist. What do you mean by that? What do you mean by that? All receptors are not for drugs. है ना? In human body, we are having multiple cells. From head to toe, our body is made up of cells. Cell is structural and functional unit of life. On all cells, we have the receptors. But that receptor is for physiological molecule. Now, I'm having receptor on my skeletal muscle for acetylcholine. Acetylcholine is not a drug. It's a physiological molecule in my body. I'm having receptors for histamine, for serotonin in my body on various organs. I'm having the receptor M1, M2, M3, है ना? Alpha receptors, beta receptors, है ना? Autonomic nervous system, sympathetic, parasympathetic receptors, I mean alpha, beta receptors on my body on various organs. You know the distribution, alpha 1 are present on which organ, alpha 2 are present on which organ, beta, beta 2, beta 3, they are present on which organ, है ना? Muscarinic receptors and histaminic receptors, serotonin receptors, multiple receptors. So these are for physiological molecules. Alpha 1, alpha 2, beta 1, beta 2, these receptors are for adrenaline, noradrenaline. Okay. M1, M2, M3 are for acetylcholine. These are for physiological molecules. But whenever we take a drug, the drug binds with all these receptors, okay, and shows its action. So there are 4 possibilities. Imagine this is a cell membrane and these are the receptors. Let me draw the receptors. This is a receptor on the cell membrane, receptor on the cell membrane, receptor on the cell membrane, receptor on the cell membrane. Okay, now this is a drug coming and binding. Binding is already there. Drug coming, the red color is the drug. The drug is coming and binding with the receptor. Means affinity is there. Binding means affinity. Now after that, how it's showing its activity? That is the intrinsic activity. है ना? Activation of the receptor. So there are certain drugs that will activate the receptor fully like that of physiological molecule. For example, this receptor is muscarinic receptor, M1 or M2 or M3. So if acetylcholine is coming and binding with the receptor, that is causing the activation. In the same way, the drug is also activating the receptor in the same way as that of acetylcholine, the natural physiological molecule. For example, this receptor is for beta receptor, alpha or beta receptor. So if noradrenaline coming and binding with the receptor, it is activating the molecule in the same way the drug is also activating. So the intrinsic activity of the drug, this is a drug, the intrinsic activity of the drug to activate the receptor is same as that of physiological molecule fully up to the full extent. So here intrinsic activity is equal to +1. It is known as +1 and these drugs are known as agonist. So this is an agonist drug. So agonist of what? Agonist of histamine, serotonin, agonist of acetylcholine. So they are stimulating the receptor in the same way as that of physiological molecule fully. So that is known as agonist drug. Okay, the second drugs, these are agonist drug. The second drug, here the drug is coming and binding with the receptor. It is also activating like the physiological molecule, but not fully, partially. It is activating it partially. So from 0 to +1. We are getting my point. For example, this is a receptor for muscarinic M1, M2, M3. So if acetylcholine is activating it 100%, it is activating only 20-30% or 40%, 50%, 80%, but partially, not 100% as that of acetylcholine. This is also like acetylcholine, but it's 100%. This is partial activation, like that of physiological molecule only, but partially. So here the intrinsic activity was complete, that is +1. Here the intrinsic activity is 0 to +1, and these drugs are known as partial agonist. These are known as partial agonist. You are getting my point? So here we imagine acetylcholine, so it is activating the receptor like acetylcholine 100%. Here it is acetylcholine, here it is activating like acetylcholine, but partially, not 100%. Now again there is a drug coming on the third one. Again there is a drug. Okay, it is coming and binding the receptor and doing nothing, literally doing nothing. Let me write down. It's doing nothing. Neither it is activating the receptor, nor it is doing the inhibiting the receptor. Nothing. It is just blocking the receptor. It is doing nothing. It is just blocking the receptor so that natural physiological stimulant is not coming and binding here. Okay, natural thing is not coming. So suppose this is a receptor for M1. So normally acetylcholine come and bind here, but since the drug is blocking it, so acetylcholine cannot come and bind here and cannot show its action. So it is not activating like acetylcholine. It is not doing the reverse. It is not doing anything. It is blocking. So this drug is known as antagonist. What does this drug known as? It is known as anta. So please learn, it's very confusion. Antagonists do nothing. Here intrinsic activity is equal to 0. It is just blocking the receptor. It is doing nothing so that natural physiological molecule cannot come and bind. That is antagonist. And last category, here also we have a drug. Here also we have drug. The drug is coming and binding with the receptor and activating it reversely. For example, again it's a muscarinic receptor. And here normally acetylcholine used to bind it. So whatever acetylcholine is doing here, it's doing the reverse. If acetylcholine coming and binding here and doing the contraction, it is doing the relaxation. If acetylcholine coming and doing the relaxation, it is doing the contraction. It is doing reverse of that. So this drug is known as reverse agonist. Here intrinsic activity is equal to -1, and this is known as reverse agonist. So we have 4 types of drug. What are the 4 types of drug? Please say, based on the intrinsic activity. If intrinsic activity is equal to +1, it's agonist. If intrinsic activity is 0 to +1, it's partial agonist. If intrinsic activity is 0, it's antagonist. If intrinsic activity is -1, it's reverse agonist. So please understand it. How many of you got it? Give me a thumbs up. How many of you didn't got it? Kindly ask me to repeat. Write down in the chat box right now. Please write down. Write down in the chat box. You got it or you didn't got it. So based on intrinsic activity, we are having 4 types of drugs. The names are in front of you. So based on intrinsic activity, these are the 4 types of drugs. So agonist, here the intrinsic activity is +1. Partial agonist, here the intrinsic activity is 0 to +1. Antagonist, here the intrinsic activity is 0. And inverse agonist, here the intrinsic activity is equal to -1. Yes, everyone got it? Everyone? Okay. So this is the same thing, you can see it here. If the intrinsic activity is 0, it's antagonist. If it is partial, 0 to +1, here intrinsic activity is equal to 0. Here intrinsic activity is equal to 0 to +1. Here intrinsic activity is equal to +1. It's agonist. And here intrinsic activity is equal to -1. It's inverse agonist. I hope you got it. Okay. Now the last thing in the pharmacodynamics, so general pharma will be done after that. The last thing in the pharmacodynamics I want to teach you here is the dose response curve. Let me explain you DRC. DRC, dose response curve. The name itself depicts meaning. What do you mean by DRC? Dose response curve. DRC. It's a curve. Curve means what? Curve means graph. So it's a graph. It's a graph between 2 things. Let me draw the 2 things. Dose response curve. Let me draw a graph. It's a curve, na? Curve means graph. So it's a graph. It's a graph between 2 things, the dose and the response. So what is the dose? What is the response? Hana? So we take the dose of the drug we are taking. Hana? The dose of the drug on the x-axis. And the response in my body, there will be some response because of the drug. So response on the y-axis. So always we take the dose on the x-axis and response on the y-axis, and we make a graph of that. Imagine I'm having headache. You are a doctor, you are a very good doctor, and you are prescribing me some drug. Ma'am, take this, you will have better feeling and your headache will be gone. So I'm taking that drug. So what will happen? So as soon as I have taken the drug by any route, so initially the drug will absorb, and I will have response. So initially the concentration of the drug, as the concentration of the drug will increase in my blood from 0. From 0, as the concentration of the drug dose will increase, the response will also increase. So my headache will fall. I mean, my headache will reduce. I will feel better. The dose will increase. I will have a better response. There will be a maximum response, even which after that, if you are increasing the dose, there is no reduction in the headache. For example, I'm having 100%. If I quote my headache right now 100%, and you are giving me a tablet, ma'am, take this tablet, you will feel better. So I'm having better, but maximum it is fall to 20%. 80% is reduced, but 20% still I have the headache 20%. Even on taking more tablet, it is not reducing. So this is the maximum response this tablet can give, this drug can give. You are getting my point? So if you are increasing the dose, the response will increase. Increasing the dose, the response will increase. Increasing the dose, the response will increase. Increasing the dose. But after a point, even on increasing the dose, the response will not increase. So this is normal curve. I hope you are getting it. DRC ka meaning. You are getting my point. For all the drugs, it's like same. Don't take the example like headache. Take some other example. For example, I'm hypertensive. My blood pressure is more. Okay, hypertensive. You are a doctor. I'm coming to you. You are measuring my blood pressure, sphygmomanometer. You got, mom, you are hypertensive, and constantly on 2-3 readings, it's hypertensive only. You will put me on antihypertensive treatment. So you will give me antihypertensive ACE inhibitors or whatever drug. The first line drug you will give it to me. So just suppose my blood pressure right now, let's talk about systolic only. My systolic blood pressure right now is 180 mm. Normally it's 120, but currently I'm highly hypertensive. My systolic blood pressure is 180 mm, and you are giving me a little dose of the drug. So my blood pressure will fall a little bit. So it become 175. Still I'm hypertensive. You are increasing the dose of the drug, so the response will increase. Dose of the drug, the response. So response increase. So from it become 170, it become 160, it become 150, it become 140, it become 130. After 130, it become constant. Even you are increasing the dose, the response become constant. So this is the maximum response a drug can give. Now you have to add another drug if you further increase the response. You're getting my point. So this is the curve. This is the curve. So what is the shape of this curve? This is known as DRC. So in DRC, dose response curve, make a curve. Make a curve. Curve between two things. What two things? Dose and response. Take dose on the x-axis. Okay. And take response always on the y-axis. This is response. Response on the y-axis. So shape is always like this. This is the shape. This shape is known as hyperbola. This shape is known as hyperbola shape. What is the shape known as? Hyperbola. But there is a problem. The problem is that calculations on hyperbola is difficult. On hyperbola, we cannot do the comparison and calculation. So let's do a little bit change. Little bit change. So if I am taking dose on the x-axis and response on the y-axis, this was normally I was doing. So the shape was like this. You understood it. But instead of dose, if I take logarithm of the dose, you know logarithm. So if the dose is 10, take log 10. If the dose is 20, take log 20. Have you read logarithm in mathematics in your childhood? So there is a logarithm of the dose. And here you take response only. Here you take no change in response. Okay. So instead of hyperparabola, the shape will become sigmoid. The shape. So doing calculations on sigmoid is easy. So on hyperparabola, the calculations are difficult. We cannot compare multiple drugs. But in sigmoid shape, the calculations are easy. Hai? So here, instead of taking dose response curve, we are taking log dose response curve. Because the shape is the sigmoid, you get questions on that also. Got my point? So this is dose response curve. So we are taking the log of dose here and response here. And we will get a sigmoid shape. This is DRC. How many of you didn't got it? Anyone who didn't got it? So this is DRC. See the shape hyperbola. Hyperbola shape. And this is log DRC. See the shape is sigmoid. See the difference between the two. Okay, here the x-axis is having dose. The y is having the response. Here x-axis is having log dose. The y is still having the response. So there is only one difference. So we follow this, we don't take this for easier calculation. Now this is log DRC. You will say, ma'am, it's all okay, but being a doctor, how it is useful for me? I'm a doctor, I'm not a statistician, I'm not a mathematician. So how it is useful for me to calculate the log dose response curve for my patient? So I'm interested in treating my patient. My only purpose is to treat my patient. So does it important for me to know? Yes, of course it's important for you. Let me explain you why. It gives you 4 information. Very important for your patient. It gives you 4 information. So whenever you give prescription to your patient for anything, you must see these 4 things. Before prescribing a drug to your patient, you must see the DRC of that drug and take these 4 information and then prescribe the drug to your patient. What are the 4 information you are getting here? Number 1, you will come to know which drug is more potent. If you have multiple options for a disease, which is more potent, you come to know which drug is more efficacious. Based on the slope, you come to know whether the drug is safe or unsafe. And based on the therapeutic index or therapeutic range, you will come to know again the drug is safe or unsafe. Let me explain you these things one by one, how it is important. It's very easy. Hana, Shekhar, it's very easy. Please concentrate. It's very easy. Hana, now you are a doctor. Once you start your practice, now many MR will come to your clinic. MR are medical representative. I'm sorry. There are many pharmaceutical companies which make drugs for various diseases. For example, let's take an example. There is an example, paracetamol. Hana? Paracetamol, PCM. I'm really sorry. Paracetamol is a drug which is antipyretic drug. We take this drug in fever. It reduces the temperature. It is an antipyretic drug. How many brands are available? Simam Crocin is the most common brand or famous brand, you can say. We take Crocin. Crocin contain what? It contains paracetamol. There is Calpol, if you have heard. There is Dolo, if you have heard. So all of them contain paracetamol only. The composition is same, but the brands are different. The companies are different which are formulating it. Now all the companies will claim that my drug is best, my is best, my. But if you see, they all contain 500 milligram or 500 gram of the paracetamol. So how to decide which is better for our patient? It is not only the costing which matters. Okay, the one which is the cheaper, the one which is the costlier. You cannot prescribe like that. You have to see the DRC of that. Ask the medical representative, show the DRC of your drug. Then decide, see the potency, compare the potency of all, compare the efficacy, compare the slope, and then you can decide. So being a doctor, it's our moral responsibility to give the best drug to our patient. Before prescribing, you shouldn't see only the composition. You should see its various properties also, because various brands are providing the same composition. You are getting my point. So it's us, the doctors, who are the one who will decide the best drug for their patient. Oh, it is your moral responsibility. Okay. Now let's talk about them one by one. So what is potency and what is efficacy? You don't understand that. Let's come on the potency. What is potency? Suppose I'm having two drugs. Can you see the two drug A and B? This is the DRC of the two drug. Both the drugs are for the same disease. For example, the patient is having malaria. For malaria, two drugs are available. Company A drug and company B drug. Both are claiming my drug is best. My drug is best. Let's see. Anna, let's see. We will compare the DRC of both drugs. Then we will decide which is best and we will decide ourselves for our patient. We will not go what the MR is saying. We will decide by ourselves. Anna, what is best for our patient. Okay. So this is the two drugs for the same disease. Any disease. Hannah, both the companies are claiming my drug is best. We will compare the DRC and we will decide. Okay, chalo, let's see. So here you can see this is the logarithm of the dose on the x-axis and on y-axis it is the response. It is the response for the patient. Hannah. So for a particular, what I want, my target is if the patient is taking the drug, at least 50% improvement should be there. Then it is worth to give the drug. If even 50% improvement भी नहीं हो रहा किसी drug से तो फायदा ही क्या है देने का. So ऐसा मेरा सोचना है. So what I am thinking, at least the drug should give 50% response. After taking, at least 50% of the disease is cured. At least. If it is more than that, it's good. But at least 50% response is there for my patient. So I will take 50% of the response. 0.5 is 50%. है ना? So for 50% response, how much milligram of A has to be given? 30 milligram of drug A has to be given. And for the same 50% response, how much milligram of B has to be given? 60 milligram of B. So you tell me which drug is more potent. So 30 milligram of A give 50% of the response. And 60 milligram of B give 50% response of the same disease. The disease is same. Whatever is the disease. Disease is headache, disease is hypertension, disease is dengue, malaria, whatever is the disease. Okay, response. We are looking at the response. For 50% response, different doses are required. So this has to be given 30 milligram, this has to be given 60 milligram. So drug A even at low concentration giving 50% response. And drug B require high concentration to give 50% response. So which is more potent? ज़्यादा ताकतवर कौन है? ज़्यादा ताकतवर कौन? वो है जो कम डोज पे ही ज़्यादा काम कर रही है ना? So the drug which is more potent at low concentration, it is giving high response. Drug A is more potent than B. Can I say drug A is more potent than B? So if two companies are there, both MR are coming to me. Hannah, madam, my drug is best. Prescribe this one for your patient. Madam, my drug is best. Prescribe this drug for your patient. I will compare. I will say it's okay. I will compare. I will decide. Hannah, don't you say, you show me your DRC. So this is DRC of A. This is DRC for B. The disease is same. Hannah, I will see the response. For 50% response, how much milligram has to be given? For 50% response, 50% is just a guideline. You can take one thing. Either 60 of both, 70 of both, 80 of both. Take one thing. So if I want 50% response of both the thing, how much milligram this is required, how much milligram this is required. So the one which is required in lower concentration for a particular response, that is more potent. So I will decide by myself. So this is how we compare the potency. So potency is compared on x-axis. We are looking at the x-axis. This is 30 milligram, this is 60 milligram. We are looking at the x-axis. So the rule is that, the rule is that the drug which is on the left side, you can understand, this is my right hand, this is my left hand. You see yourself, your hands. So this is the left, this is the right. The drug which is on the left side, more on the left side, more potent. More potent. The A drug is on the left side. So left side drug is more potent as compared to the right side. It is the rule. So simply you can apply the rule. So again, I'm having three drugs now for the same disease. Disease is same. The same disease. For example, the disease, say the symptom is fever. For the fever, the paracetamol is there. But different brands are there. Calpol, Dolo, or Crocin. We are comparing the DRC of all. The DRC is in front of you. So for 50% response, how much dose is required? So this one is required only 0.01 milligram. This one is required 1 milligram. And maybe this one is required 100 milligram. So the one which is on the left side, A is more potent than B than C. So the sequence of potency is A followed by B followed by C. The one which is on the left side is most potent. The one which is on the right side is the least potent. So this is how we can compare the potency. So what is potency? Summarize. It is the amount of the drug which is required to produce a particular response. It is seen on the x-axis. The drug which is on the left side, it is more potent as compared to the drug which is on the right side. I hope you got it. I will give you questions to solve. You get many questions, the graph-based questions. Please understand. Potency. Okay, you got it. Okay, ma'am, the potency. What is efficacy? I want to teach you four things. Now, potency is done. Now, coming on efficacy. Second thing. After that, I will teach you slope and therapeutic index also. So, coming on the efficacy. Second information we are getting is efficacy. What is efficacy? Which drug? The same graph. Which drug is more efficacious? Which is more potent? Acha. For potency, see left, right. The one which is on the left is more potent. Simple rule. Which is on the left? A. So potency wise, A is more potent than B. This is potency. This is potency. Now let's talk about efficacy. Efficacy mein what is the sequence? Okay. What is efficacy? Efficacy is the maximum response produced by that drug. After that it become constant. So this is the response produced by A, and after that it become constant. And this is the response produced by B, and after that it become constant. So maximum response produced by A is 70%. है ना? And maximum response produced by B, here 70 के बाद 80, 90, maybe 100%. 100%. You are getting my point. So just suppose I'm having headache. My headache is 100% severe headache. I'm coming to you, doctor, I'm having severe headache, do something. So you will say, okay ma'am, take tablet A. If I'm taking tablet A, I'm having 70% reduction in my headaches. 30 is still there. You are increasing the dose of A, but still 30% is there because maximum response produced by A is 70 only. I'm feeling 70% better, but 30% is still there. You are giving me drug B. There is another doctor who is giving me drug B. Don't take A, ma'am, take B. So after taking drug B, I'm having 100% cure of my headache. 100%. My headache is 100% cure. After that, it becomes constant. So it is the maximum response shown by the drug. It is seen by the height of the drug, height of the curve. Can you see the height? This one is a short and this one is tall. Taller the one shows more efficacy. So which is more efficacious, A or B? B is more efficacious because B is giving 100% response. A is giving only 70%. So who is more efficacious? B is more efficacious. So efficacy is seen on the y-axis. For efficacy, we see the height. We don't see left, right. We see the height. The taller the one, the more efficacious is one. So B is more efficacious than A. So if you see the potency for these two drugs, A is more potent than B. And if you see the efficacy, B is more potent than A. Because A is on the left side. The one which is on the left side, it is more potent. And B is taller. The one which is taller is more efficacious. For potency, you have to see leftness. The one which is more on the left is more potent. Leftness, left, more left, lefty. Okay. And for efficacy, you have to see the height. The more tall is more efficacious. You can compare now. Okay. Now, two MRs are present for the same disease. Madam, prescribe my drug is best. Madam, prescribe my drug is best. I will say, please, okay, give me DRC, submit your DRC. I will compare. I will decide what is best for my patient. I will decide by myself. Both of giving their DRC, I'm comparing it on one curve. So one MR, this drug, this is drug A, this is drug B. So drug A is more potent and drug B is more efficacious. So what should I prescribe to my patient now? What is best for my patient? Which is more important criteria? Potency is important or efficacy is important for patient point of view? For a patient point of view, which is more important apart from costing? Leave cost. Which is more important? Which is more important criteria for prescription of a patient? Imagine you are a patient. So if I'm telling you, I will give you a more potent drug. More potent drug means a drug which is even on less concentration will give you the response. Okay. And drug A is more potent. So drug A, you have to take only 30 milligram. But drug B, you have to take 60 milligram. Okay. So drug A is the high potent. But efficacy is the response. How much response you are getting. So efficacy is more important criteria. You will say, ma'am, I should have 100% reduction in my headache. For example, I am having headache. You are a doctor. You are giving me two choices. Madam, I am having two drugs for you. A and B. Cost is same for both of them. So I'll ask you, doctor, what is the difference between the two? You explain, then I will decide which is better for me. You say, ma'am, drug A is a drug which you have to take in low concentration. You take only one tablet, 30 milligram. But the reduction in headache is only 70%. Even on increasing the dose, we cannot reduce it more. Reduction in headache is only 70%, 30% you still have it. But you have to take only one tablet. Drug B is a drug, you have to take 60 milligram, you have to take two tablets, but there will be 100% reduction. Which should I choose? I will say, but it's okay, doctor, I will take two tablets, but there should be 100% reduction in my headache. Now, why I will take less tablet, but I will still have some less response? No, there should be 100% reduction in my headache. I will take 2, 3, whatever you say. Dose doesn't matter for me, it's okay. So efficacy is a better judgment criteria for deciding clinically. So the drug which is having high efficacy, decide that for your patient. Got it? Say yes or no. Can we go ahead? Can we go ahead? So can you decide the efficacy and potency of the three drugs ABC here? Can you decide the efficacy and potency, the three drugs here? A, B, C, the three drugs. Decide the potency for the three first and decide the efficacy. First, you tell me the sequence for potency. First, you tell me the sequence for potency for the three, and then you tell me the sequence for efficacy for the three. First you decide the potency. Potency is from the left to right. So A followed by B followed by C. Efficacy is depending on the height. The most taller is C. C followed by B followed by A. A is the shortest. So this is the sequence. So this is how we can decide. For potency, look the left to right. And for efficacy, see the tallness. So this is the summary. Now you got it. Someone was saying you have confusion in this topic. There should be no confusion. Which is more important criteria out of the two? Out of the two, efficacy is more important criteria. Efficacy, Hana, not potency. You have to see the efficacy of the drug. Efficacy of the drug. So this is the summary. Potency, efficacy. So on DRC, we are getting 4 information. 2 are done. We are getting the information regarding the potency. We are getting the information regarding the efficacy. So potency is the amount of drug which is required to produce a particular response. Efficacy is the maximum response. Maximum response of the drug which is produced by that particular drug. This is seen on x-axis. This is seen on y-axis. This is decided by leftness. More left, more potent. This is decided by height. More tall, more efficacy. And more important criteria is efficacy as compared to potency. This is the summary. People respond. I'm trying from the depth of my heart to explain you pharmacology like a cake piece. Yes or no? Like a cakewalk. Yes or no? So it's very easy. I'm making it very easy for you. But you have to respond. Okay, we will solve some questions based on potency, efficacy. DRC give you four information. We are done with 2. Potency, efficacy. We will solve some questions. After that, I will tell you 2 more. That is slope of DRC and the therapeutic index. So we will see these 2 again. But before that, let me tell you some questions based on potency and efficacy. So the first question is in front of you. See the 3 drugs ABC. First, compare their potency. Can you tell me, comment on their potency? Which is most potent? Tell me one drug which is most potent. And tell me one drug which is most efficacious among the 3 ABC. Compare. Compare ABC. Most potent. Which is more potent? Which is most potent? Which is the leftist one? The leftist one is A. A. So A followed by B, है ना? Or A or B is almost same. You can see. Leftness के मामले में there is a little bit difference. So almost same. So A and B is equal. For potency, A is equal to B, है ना? But followed by C. C is on the right side. For efficacy, see the height. Height of A and C is same. So A is equal to C followed by B. So which drug you will prescribe for your patient finally? Finally, which drug you will prescribe for your patient? A, B, C में से. Which is best for your patient? I will choose A because A is potent also, A is efficacious also. A is potent also, A is efficacious. So A is best for my patient. So this is how we decide. And many questions come in your exam. Okay. So let's come on this question. This question, can you see? First, see the four drugs are in front of you. Drug A, B, C, D. A, B, C, D. Let me ask you the question. You can see the DRC of the 4 drugs. Compare drug A and B. Compare only 2 drugs, A and B. Where is A? Where is B? A, B. Tell me the potency ka sequence and tell me the efficacy. Which is more potent, which is more efficacious? Potency, which is on the left side? A is on the left side. So A followed by B. Potency wise. Efficacy wise, the height is same. The height is same. The height is same, so A is equal to B. So which you will prescribe for your patient? Which you will prescribe for your patient? If the efficacy is same, ideally we should go with efficacy. Efficacy is a more important criteria to decide. But if efficacy is same, go with the potency. So I will give drug A to my patient. Because efficacy wise both are same, but potency wise A is more, na? So I will decide drug A for my patient. So this is the summary for A and B. My next question. Okay, we can compare different drugs. You got it. Now my next criteria, my next thing from information from the DRC. We are done with potency. We are done with efficacy. Now I'm coming on the slope. The third thing. And the fourth thing is the therapeutic index and therapeutic range. Okay, so coming on the slope. Okay, coming on the slope of this graph. The DRC. Okay, dose response curve. Coming on the slope of this graph. So you can see the 2 drugs are in front of you. This is hydralazine. This is hydrochlorothiazide. The 2 drugs are there. Okay, both of them, the DRC is shown to you. Okay, now you see everyone on the screen. This is dose, this is response. See for hydralazine. See the graph for both are antihypertensive. Suppose I am having hypertension. You are going to prescribe one of them to me. Okay, both are antihypertensive. Both will reduce the blood pressure. Hydralazine and hydrochlorothiazide. Hydrochlorothiazide is one of the diuretic and hydralazine is one of the vasodilator. You know. So both of them are antihypertensive. Okay, now which is safe for me? Let's decide. Now see this curve. See the curve for hydralazine, the red one. See this curve. Everyone see this curve. So what we are doing here? We are increasing the dose. This is the dose. This is the response. Okay, we are increasing the dose a little bit. There's a drastic increase in response. We are increasing a dose of further little bit. There is a drastic increase in response. So on increasing the dose, so from 10 milligram, I'm increasing to 15 milligram, I'm increasing to 20 milligram tablet. I'm increasing the dose a little bit, but there is a drastic fall in BP. So initially on 10 milligram, the fall in BP was 10 mm. But on 15 milligram, the fall in BP is 30 milligram. On 20 milligram, the fall in BP, the patient can go in shock. So even on little bit increase in dose, you can see a little bit increase in dose, there is a drastic increase in response. The drastic, so this is known as steep slope. Steep, it is a sudden steep slope, sudden steep slope. So if you are prescribing these drugs to your patient, you must ask the patient ki please don't increase the dose by yourself without asking me. Patient are like that now, कि ठीक है 10 का tablet doctor ने बोला है 15 का ले लो 20, how does it matter? No, it matters. If you are increasing the dose even slightest, there is the increase in response drastically. These are unsafe drugs. If you're prescribing it, give it to the patient who are aware, who are educated, who can understand the depth. And please ask them, do not increase the dose without consulting your doctor. On the contrary, see the other drug. See this graph. See the graph of hydrochlorothiazide. See this blue one, this one. Hana? So here you can see on this dose, this is the response. On this dose, this is the response. On this dose, I'm increasing the dose drastically, but response is almost same. Response is almost same. So these are safe drugs. They have flat slope. This is known as flat. Hana? So even on increasing the dose drastically, response is not much change. So these are known as flat. These are safe drugs. How many of you got it? So based on the slope, we can decide the drug is unsafe or safe. So there are two types of slope, the steep slope and the flat slope. The drugs with steep slope, on increasing the dose a little bit, there is drastic increase in response, and they are very unsafe drugs. They are very dangerous drugs. Okay, got it? Got it? And here on the slope, even on increasing the dose, the response do not increase much or very less increase. So these are relatively safe drugs. So based on the slope, you can decide. So before prescribing any drug to your patient, have a look on the DRC. If it is having a steep slope, warn the patient that don't change the dose without asking me. Don't increase it. If it is a flat, it's okay. Hana, the patient is in the safe range. Say yes. Got it? Can we go ahead? So we are done with potency, efficacy, slope. Now finally, therapeutic index or therapeutic range. The last thing. Therapeutic index or therapeutic range. So let's come on the last thing, therapeutic index or therapeutic range. First, we will see therapeutic index. Then I will come to tell you therapeutic range. These are two different things. Therapeutic index is also known as safety margin. Safety margin. Therapeutic index and safety margin is same. And then I will tell you therapeutic range separately. First, see therapeutic index, also known as safety margin. See the two DRC. These are not two DRC of two different drugs. No. These are the DRC of the same drug. You will see, ma'am, same drug having two DRC. I can see this one and I can see this one. So these are the two DRC of the same drug. One is of therapeutic effect, one is of side effect. Same drug. Hana, for example, the drug is anesthesia, one of the anesthetic drug. You know, many anesthetic drugs are there. It is one of the anesthetic drug. So anesthetic drugs ka effect is sedation. And if you give it overdose, the death will occur. Patient will go in coma and die. Hana, from the anesthesia unconsciousness. So overdose of any drug will cause a side effect. So we have two DRC. One DRC is of effect and one is of adverse effect. One is of therapeutic effect, one is of adverse effect. So what are the two DRC here? See, ma'am, the first DRC is of therapeutic effect and the second DRC is of adverse effect. See the gap between them. You are getting my point? See the gap. So, okay, take the 50% of both of them. Hana? On the therapeutic ERC, take a point which is known as ED50. Okay, at which 50% response is there. 50% response is there. That dose is known as, so at 10 milligram dose, 50% response is there. And on adverse effect DRC, this 50% is known as lethal dose, at which 50% of the population dies. So at 40 milligram, 50% of the patient dies. So see, 40 upon 10, the ratio, this is known as LD50. This is ED50, this is LD50. So LD50 upon ED50 is known as therapeutic index. That is 40 upon 10. That is 4. So 4 times. So ideal dose is 10 milligram. So from 10 milligram, you can increase it to 20, 30. But if you give 40, the patient will die. the patient will die. So up to 4 times you have the margin. The dose can be increased to 4 times, but before that means dose. So there is a wide range of safety. Hana? So if I'm giving 10 milligram, it's an ideal dose, but by mistake, if I get 20 milligram to my patient, it's okay. The patient will not die. Even on 30, there is a risk, but even there are chances patient can survive, but on 40, patient will die. So up to 4 times I'm having the margin. So this is known as safety margin. What is the formula of therapeutic index or safety margin? What is the formula of therapeutic index of safety margin? The formula is the ratio having a numerator and a denominator. The numerator is ED50 and the denominator is LD50. This is effective dose 50. This is lethal dose 50. Effective dose 50 and lethal dose 50. How many of you got it? So this is therapeutic index. Therapeutic index. So this is the formula. Lethal dose 50 upon effective dose 50. This is the formula. Lethal dose 50 upon effective dose 50. So this is therapeutic index. Now coming on the therapeutic window, therapeutic range or therapeutic window. Here also we have 2 DRC, the same 2 DRC. Okay, this is therapeutic effect. This is adverse effect. Have a look on the 2 DRC of the same drug. The drug is same. Okay, what do you want? What do you want in your patient? You say, ma'am, at least my drug show minimum effect. That's why if you are a doctor, I'm a patient, you are giving some drug to me. At least to my disease, it show minimum effect. Then I will show, yes, doctor, I'm having a thoda bahut effect. Not much, but still I'm having headache, but it's little bit reduced. So at least it should have minimal therapeutic effect. This is the dose at which minimum effect come. Suppose at 10 milligram, minimum effect come. If you increase the dose, more effect will come. But at 10 milligram minimum, then less than 10 milligram, there is no use to give. If you are giving me a 5 milligram tablet, I don't even have fall in my headache 1%. I'm still having 100% headache on 5 milligram. There is no use. On 10 milligram, I'm having minimum effect. So this is the minimum dose at which a minimum effect is there. And this is the dose, say it 100 milligram. Maximum tolerable side effect is there. Maximum tolerable. After that, the patient will die. So you have a range from 10 to 100. You have to do risk and benefit analysis in your patient. Okay, you will increase the dose from 10 to 20, 30, 40. The headache will reduce, or the disease will fall. But the side effect will also come. Okay, side effect. So patient can tolerate the side effect also. ऐसा भी नहीं है कि हमको disease पूरा ठीक करना है और side effect देके मार देना है ना? We are a doctor. We have to do the risk benefit analysis. That is the most important thing in the cure of any disease. So you are giving a dose at which the effect is there, but the side effects are bearable. You have to manage at that dose. Okay, so this is the range. So the range is from minimum effect to maximum bearable side effect. So this difference is known as therapeutic range. Therapeutic window. You have to hold on at certain point. You are getting my point. You're getting my point. So for example, for some drug, the minimum dose is 10 milligram. Before less than 10 milligram, it don't show any action. So the minimum dose is 10 milligram, at which it shows a little bit of action, a little bit of cure in the disease, a little bit of response. But up to 100 milligram, we can give at 100 milligram maximum tolerable side effect. More than 100, the patient can even die or severe side effect, severe paralysis, severe coma, patient cannot tolerate. Patient cannot tolerate. So we have a range from 10 to 100. We have to balance in between. That is known as therapeutic range or therapeutic window. So wider is this range, the drugs are safe. But imagine the drugs which is having a very low therapeutic index. Imagine there is a drug which is having very low therapeutic index. For example, it is starting at 0.5 and ending at 0.7. So 0.5 milligram to 0.7 milligram, you have to balance. So at 0.5, it starts showing its action. Before that, it don't show its action. And at 0.7, it shows severe side effect. So the range is very low. Okay, that is the drugs with narrow therapeutic index that are dangerous drug. That are very dangerous drug. Okay, for these drugs which is having very narrow or low therapeutic index, we have to do the therapeutic dose monitoring. Okay, this is a list of drug for which we have to do therapeutic dose monitoring. What do you mean by therapeutic dose monitoring? We have to take the blood sample and check how much drug is present in the blood. For example, my patient is on digitalis. Okay, the patient is having heart failure. Digitalis is a drug which is having a very narrow therapeutic range. So absorption is different now. There are 3 different patients. I'm giving the same tablet, 0.5, 0.5 milligram. But the absorption is different. Maybe the first patient is absorbing maximum of that. Maybe second is not absorbing. Third is a very poor absorber. So how much present in the blood, that matters. But how I come to know how much present in the blood? Because the range is very narrow now. In the first patient, it can cross 0.7 because it is absorbed very well. You got my point. In the second, it may not even reach the therapeutic level. So I have to take the blood sample in a test tube and check the level of the drug. That is known as therapeutic dose monitoring. We have to do it only for the drugs which is having narrow therapeutic index. So there is a mnemonic to learn these drugs. The mnemonic is a drug possessing low therapeutic index. 6 drugs are there. A, aminoglycosides. Okay, aminoglycosides. Drug, D for digitalis. P for phenytoin. L for lithium. T for TCA, tricyclic antidepressants. And I for immunomodulators. So these are the drugs which is having low therapeutic index. How many of you got it? We are done. So I am done with DRC, dose response curve, in which I taught you to make a curve between two things. On the x-axis, take the logarithm of the dose of the drug, and on the y-axis, take the response of the drug. You will get a sigmoid shape. Okay, you can take multiple drugs to compare. And you can compare, you can get 4 information from here. You can comment on the potency of the drug, which is more potent. You can compare the efficacy of the drug, which is more efficacious. You can comment on the slope. Based on the slope, you can see a steep slope or a flat slope, which drug is safe, which is unsafe. And you can comment on 2 things, therapeutic index and therapeutic window. Okay, I told you all these things. Yes or no? So let me revise. Potency, lefter is the drug is more potent. If it is ABC, A is most potent drug. Left. Efficacy depends on the height. The taller is the slope, the more efficacious drug is. So A is tall only. So A is more potent, A is more efficacious. And out of the two, efficacy is a more important criteria as compared to potency for deciding the patient. This is the deciding criteria. Slope, there are 2 types of slope. Steep slope, they are dangerous drug, and flat slope, they are safe drug. Therapeutic index and therapeutic window. Here also we take the 2 DRC, one is of therapeutic effect, one is of side effect. Here also we take the 2 DRC, one is of therapeutic effect, one is of adverse effect or side effect. Here we take the 50-50% of both, and we take the ratio LD50 upon ED50. Okay, that is therapeutic index. Here we take the difference between the two. We don't take 50-50%. On the therapeutic, we take the minimum response. And here we take maximum side effect. And we see the difference between them. You're getting my point? You want a clarification on therapeutic index and therapeutic window? Or you got it? Many students may have confusion in therapeutic index and therapeutic window. Let me explain you once for all. Hana, therapeutic index is what? Also known as safety margin. And therapeutic window, also known as therapeutic gap, is what? For both of them, we make 2 DRC. The first DRC is for therapeutic effect for the same drug, and second DRC is for the adverse effect or side effect for the same drug. Now please see. Here we take 50%, 50%. So this dose is known as ED50 and this dose is known as LD50, 50-50%. We take the ratio of the two, and that is therapeutic index. Therapeutic index or safety margin, that is 50-50%. LD50 upon ED50. It is not ED upon LD, LD upon ED. Okay, but here for therapeutic window or therapeutic gap, we don't take 50-50%. No, we don't take. Here we take the minimum response and maximum adverse effect. The minimum response is this, and the maximum adverse effect is this. And the difference between the two, difference between the minimum response and maximum adverse effect, maximum acceptable adverse effect. The difference between the two is known as therapeutic window. So it is the difference between maximum adverse effect and minimum response. So I hope you are getting it. I tried my best from the depth of my head to explain you the difference. Okay, got it? Yes, efficacy dekhkar decide karna hai, Shekhar. Absolutely right. Okay, therapeutic index, you got it now? Kirti Vasan, you got it? So this is the complete thing, the complete information, you got it. So we are done with complete general pharmacology. How was the session? You got the complete. I taught you complete pharmacokinetics as well as complete pharmacodynamics. Here I taught you absorption, distribution, metabolism, excretion. Here I taught you the mechanism of action of the drug based on affinity of the drug, based on intrinsic activity of the drug. And I taught you DRC here. How many of you got it? Yes. Was it easy? Was it difficult? Now the complete systemic pharmacology is there. In the complete systemic pharmacology, these all systems are there. All these systems are there. So I will cover all these systems in 2 more sessions. Okay, one is tomorrow. Another I will ask the team when it can be scheduled. So 2 more sessions, again 3 or 4 hours I will take. So tomorrow there is a session at 9 a.m. in the morning, the same timings like that of today. So tomorrow I'm covering the 5 systems in the morning. I will start with the antimicrobial. It's a very big system. I will start with that. I will teach you all important antimicrobials in your syllabus. Then we will come on diuretics and antidiuretics. Then we will come on anti-asthma drugs for asthma. And in the CVS, the heart failure drugs, anti-arrhythmic drugs, anti-hypertensive drugs, and drugs for angina. We will cover these 4 chapters in the CVS. And if the time allows, we can start with the CNS also. And the day after tomorrow, and whenever we have the episode number 3, we will cover remaining all these systems. So this is a rapid revision of entire pharmacology and all the things, all important chapters we want to cover. I do not want to skip even a single system. Okay, so right now I would like to end the session. Thank you so much for your cooperation, for your time, for your presence here. Hope to see you again tomorrow morning 9 a.m. Tomorrow morning on 18th of June, 9 a.m. in the morning, again for 3 to 4 hours. The session timing will be 9 to 1, 9 to 12 or 9 to 1 p.m. It will be the session timing, and we are going to cover systemic pharmacology. The general is done. Any specific things you want to say or you want from my side to teach you, you can write down in the comment section. Okay, anything else you want to say? Thank you so much. Yes, I will cover ANS also, anti-cancer, CNS. I will cover everything. Don't worry. I do not want to skip even a single thing. The only thing, I should get the enough sessions so that I can cover this completely. Okay. So in the 2 more sessions, I can cover all these completely in a crisp manner. Okay. It's a rapid revision. I assume you know the basics. Okay, so thank you so much for being with me. I'm just ending the session. Hope to see you again tomorrow. Ask your friends, colleagues, all the students who are going to appear in any of the competitive medical entrance exam. They can attend the session tomorrow. Systemic pharmacology. I'll start from the scratch. Okay, bye bye. See you. I'm ending the session.